Ah,
A very warm good evening to one and all. Welcome to 31st Annual Conference of the Indian Society of Organ Transplantation. On behalf of everyone present here, I would like to thank Dr. Jai Prakash, President of ISOT, Dr. Vivek Kute, Secretary of ISOT, Dr. Narayan Prasad, Treasurer of ISOT, Dr. Abhi Abraham, Organizing Chairman of ISOT 2021, Dr. Rajesh R. Nair, Organizing Secretary of ISOT 2021, Dr. Maman John, Treasurer of ISOT 2021, for spearheading this grand event. A big round of applause, please. Once again, welcome to 31st Annual Conference of Indian Society of Organ Transplantation. Today's scientific program is by the Society for Heart Failure and Transplantation. I would like to welcome the esteemed panel, starting with the coordinator, Dr. Kumud Dittal, who is the Program and Surgical Director of Heart and Lung Transplantation of Sparsh Hospital, Bangalore, Kaveri Hospital, Chennai, and Amrita, Kochi. He is the Chair of Heart and Lung Committee of Transplantation Society and is an expert in the management of end-stage cardiopulmonary failure with surgical practice in heart and lung transplantation and MCS. His specialist interest in educational, translational research, donor organ preservation, DCD heart and lung transplantation, and pulmonary endarterectomy. Next, we have the chairman, Dr. Jose Chaco Periyapuram, who is senior consultant cardiac surgeon and performed the first successful heart transplant in Kerala and first successful heart-free transplant in India. Dr. Jose is a fellow of Royal College of Surgeons, Edinburgh, Royal College of Surgeons, Glasgow, and Royal College of Surgeons, London. He is the founder chairman of Heart Care Foundation, a charitable trust that financially assists poor heart patients. Next, we have the secretary, Dr. Manoj Raj, who is a cardiothoracic surgeon in Sahyadri Hospital, Pune. He performed the first heart transplant in Pune and is the first Indian surgeon to perform pediatric cardiac surgery in Nigeria and the first off-pump coronary surgery in Yemen. He runs a charitable trust which helped hundreds of children undergo free open heart surgery. Coming to the members, we have Dr. Nanda Kumar, who is the president and the director of cardiac service, Metro Hospital, Calicut. And we have Dr. Julius Punnan, who is the vice president and senior consultant of cardiac surgeon at Narayana Health, Bangalore. He is surgical head for heart and lung transplantation and mechanical circulatory support at Narayana Health. Next, we have Dr. Jabir Abdullah Kuti, who is the secretary. He is a renowned senior cardiologist with experience of 19 years in cardiology practice. He is a well-known face in national and international level and is the office bearer of the Cardiology Society of India. Now, coming to today's program, we have infrastructure, training, and capacity building. In session 1 is the current status, coming to national resources, funding, and expertise Q&A. The moderator will be Dr. K. Dittal, and the speaker will be Dr. K. Sarkar. Over to you, sirs.
Okay, well, thank you very much. You've done most of my work, which is very good. Thank you so much. I'd like to thank the ISOT and Society of Heart Failure and Transplantation to put this program together, and the colleagues in the team who have been so invaluable in helping me put it together and selecting the chairs and together getting the speakers, and some of which are international speakers, and we're very lucky to have them at such short notice. And I think today is really about what's happening in India, what the playing field is for us. And tomorrow will be a bit more exciting in terms of the future and how we think the direction will change for our discipline. So without further ado, I'm going to start by asking Dr. Sarkar to speak on the current status of national resources, funding, and expertise. And we will and then have the question and answer sessions after every talk. Thank you. Kunal,
yeah, is the screen visible?
Yes, it is. Great. Fabulous.
Kumut, and to all my friends in ISOT, thanks a lot. And I'll try to give you an overview of the thoracic organ transplantation. There were certain sub-agendas in it. Let me see how much of that measures up to my wisdom. And without any concealment, I must acknowledge that I was a bit floored by the spectrum of the topic, and I borrowed heavily from the wisdom of my friends, Sandeep Atawar, Anwar Muley, Julius Punen, Jose, and of course, Dr. Bala Krishnan. Wait a minute. Well, this is a smile, you know, that water smiling on the 3rd of December, 1967. And 1967, honestly, was a great year for interventional medicine because perhaps not many of us realize that the same year in the month of May, you had the first acknowledged coronary bypass. Somewhere in the middle, you had the first liver transplant. And before the year ended, in the same year itself, you had the Christian Barnard with his breakthrough heart transplant in Grote Schuur. Fair enough. Now, where does that take us now? Now, we are placed in a speak because we'll probably discuss about 2018 because 2019 and 2020, the leaking door of a refrigerator from the lab in Wuhan in China has kept us busy. So let us focus still about what was happening in the world in 2018. Until 2018, we think that we were managing little less than 40,000 disease organ donors worldwide, 77% of which was essentially from brain death, which means that there was a fair percentage from our circulatory death donors were also increasing. And the global numbers of heart transplant hovers around the 3,500 mark. And one good thing to see is thanks to the effort of the society and many others, that over the past few years, whether it is in blue or yellow, the hue of India has been gradually deepening from what it used to be literally blank half a decade ago. I think the transplantation and organ donation hue of India is intensifying, looks good. Obviously, all of you are aware of the fact the Indian journey starts in the hands of a great artist and a great surgeon, P.K. Sen, in February 1968. And finally, the clinching achievement was that of Dr. Venugopal. And his achievement was even more astounding because he did the first acknowledged transplant in AIIMS, which was 48 hours before the Human Organ Transplantation Act itself was passed. So the first sort of acknowledged heart transplant in India was done without the Human Organ Transplantation Act. So this was proactivity at its best. Some of the important timelines. Now, I'm not going to split hairs with you regarding the legalities, but few things are important. So in 1994, 2 days after Dr. Venugopal had done the first transplant, we had the HOTA approved in the Indian Central Assembly. 2011, HOTA undergoes some amendments. And 2014 is an important time because in response to a lot of things that was happening all over the country, the national entity of NATO comes in its existence. Transplant centers in India. Now, well, we are a huge country, a lot of people, those are the givens. This is borrowed a slide from one of Bala's presentation where he tries to point out that which of the Indian states are blessed with a transplant program. So we will look at the number, the distribution, the workload, and I confess we don't have any sort of cross-checked outcome data available. Fundamental question is, are we in an atmosphere of scarcity or is it an atmosphere of clutter? As far as heart transplant is concerned, I think in the last count, about 74 centers were accredited in the whole country. And this is the lie of the land. Obviously, Tamil Nadu is leading the pack with a little less than 30 centers, followed by Telangana, then Kerala, Karnataka, Maharashtra, and the rest of it. So if we look at the regional distribution, the thoracic transplant centers, heart and lungs mainly put together, that there is definitely an unambiguous majority of south of the country, which has 52% of the centers. The north follows with 25%. This is we're just counting the centers and the region. The west follows with 20%. And us in the East were a little bit late to get to the starting block. We contribute to about 3% of the total centers the country has. The total heart and lung transplant, the total heart transplant activity since 1994 shows us that there was more than 1,000 hearts have been put in India, about 101 heart and lungs, about 338 lungs. I mean, the numbers in itself are not too bad, but consider the fact that this is spreading out over about 27 years. So fair enough, we've at least made a decent start. If you consider 2018, as far as 2018 is concerned, the NATO data tells us that we had about 241 hearts, 191 lungs. Obviously, there was a far more liver and kidney, because kidney is a different cup of tea. It's a little bit of a cash and carry enterprise. Liver has the facility of operating on sort of split donation and living donors. But heart and lungs have been lungs, but obviously a little bit higher. Heart is staying around 241. And this gives us a kind of a strike rate of around 3.5 transplants per unit per year. And I leave it to the collective judgment to consider that whether that should be considered to be optimal. Now, if we now look at that, how are these transplants which have been done over, say, 25 plus odd years, how are they distributed across the region of the country? Then over this quarter of a century, our experience with transplants, south of the country leads the field with 65%. The West has just been pipped to the post the north of the country by 18%. North of India stands at around 14%. And the East, which has been late starters, just contribute under 5% of the total activity at this point of time. Well, effective transplant program, like most things in medicine, obviously will depend upon the sense and the comprehensiveness of a healthcare delivery system. You know, I cannot get into the details of this slide. This is a graphic from my book, which has recently been published, called The Sickness of Health, and where you have government insurance, totally private, a mixture of private and government insurance. And you get to countries like Pakistan, Bangladesh, and most of Africa, where there is no insurance of any description at all. Now, in India, the current healthcare has evolved because of, it's like administered chaos. It has evolved out of default. It has not evolved out of a plan. And should anybody ask you anything to do with Indian healthcare, just remember the 60-40 formula. It holds good for everything. 60% of procedures are done in the private sector, but 40%, about the 20 lakh beds that we have in our healthcare, is in the private sector. And take note of the fact that this number is very static. It's been 5 years since there's been any substantial increase in India's built up healthcare capacity. And 40% of the total expenditure, in spite of the fact that over the last half a decade, we've had many health schemes littering the country, out of pocket payment in healthcare had stayed very much static at around 40%. So what is the sense? What is the sense we are getting out of it? Now, if you get into the transplant program, what kind of model are we trying to follow? Are we trying to follow the American model? Because the way I look at Indian healthcare overall, a very simplistic statement is that Indian healthcare is equal to American healthcare minus the money, because it's equally chaotic. In India, in the United States, you have 50 states with 51 different healthcare systems, a little bit of similarity, a lot of differences. They have more than 250 centers, which are largely funded by Medicare as far as the transplant activity is concerned. And what is very surprising is I really have no experience of working in American transplant programs that should a large number of 250 cardiac transplant centers, they do about 3,000 per year. That if your number or your outcome is considered to be suboptimal, you do a self-audit And it is like a weekly confession that you go out to your authorities, whoever that may be, and you say, look, I don't think I'm cut out for this job. So you take myself off from the transplant program, and there you go, one number short. I don't honestly have the data that this self-audit and self-regulation, how often that actually happens. The other contrast is a kind of organized and what you may call a boringly socialistic system, like you find in United Kingdom and Australia to some extent. I'm a little bit familiar with what happens in United Kingdom. And United Kingdom, prior to the late 90s, as late as 1997, 98, was an equally chaotic picture, where every cardiac center pretended to be a transplant center. Then they tried to get their act together, and currently they have about 7 centers, and they do about 300 hearts and 120 lungs per year. So I think societies like ourselves will have to answer the question that what is the sense of direction that we are going as far as transplant services in India are concerned. It's a bitter pill, but we've got to touch the bitter pill, leave alone swallowing the bitter pill at some stage. Are we going to be regulated? Will somebody else regulate us? Are we going to be self-audited, or are we going to be restricted? So I think the jury is still out, because perhaps it'll take a little bit of time for the dust to settle in the post-pandemic era before we have answered this crucial question. But I have no doubt in my mind that this question has to be answered pretty sooner rather than later. The pandemic obviously has not been a great help as far as interventional medicine and procedure-based therapy is concerned. And in India, the first wave was a big curse, because the first wave was done in the right month in the wrong year. It should have happened. The great lockdown of March 2019 literally flattened healthcare of all kinds of activities. And I think as far as non-COVID activity of Indian healthcare in general was concerned, it shrunk to about 10%. Fortunately, everyone, the 15 major states of India had 16 different versions of the second lockdown during the second wave. So there was reduction in elective activity, but not to the extent of 90%. It decreased by 70%. And the other week, I was doing a talk at a cardiological society, and there is a feeling that about 10% of the smaller interventional cardiology and cardiac surgical centers are probably fighting for their life in trying to make up post-pandemic state. So if you put your ears to the ground, I think activity is picking up post-pandemic, but I believe the industry is not entirely back to the normal. Disease organ donation, once again, 2019 and most of 2020 is probably not a true representation of what's happening. But the diseased organ donation is kind of reached a plateau over here, and there's been a little dip noticed in recent times. The number of hearts are staying reasonably constant. Now, once again, Bala does a very elegant review in the Indian Journal a few months back, and he's pointed out optimistically towards a continuing upward trend in the number of hearts that we've been doing. But that has to be viewed in the same perspective that even though the number of hearts done have held on, the number of organs donated is on a downward trend. Again, there's been a lot of external factors at play. So I think it's too early to take a very dogmatic view of this situation. And as most of you are aware of the fact that organ donation in India is both good news and bad news. It is good news because it's been increasing over years, and it's bad news because obviously the numbers look very, very minuscule as compared to the American and the Asian donation, the American and the European donation rates per million. NATO tries to congratulate itself with the fact that pre-2014 and post-2014, I think their claim has definitely some substance to it. That if you look at the donations per million population, pre and post NATO state, it is definitely has increased from 0.27 to 0.65. The three states that is quite ahead of the pack as far as the disease or the organ donation is concerned is Maharashtra, Tamil Nadu, and Telangana. And these states have been, I think there's a little bit of sibling rivalry, because if you read the popular press, certain months Maharashtra takes the award, hands it over to Tamil Nadu, and then Telangana says, no, we have done better. It's good, it's healthy rivalry, it's a little bit of structured competition, and these three states continue to be heading the pack in organ donation. A little bit of concern, you cannot help but observing that since 2016, this is way before the pandemic, that since 2016, the numbers of organ donation from Tamil Nadu, because why is Tamil Nadu important? It goes without saying. It's been the main piston driving India's transplant program, the state in general, and the programs led by Dr. Balakrishnan themselves. It's been the main piston that lifted India out of the Rip Van Winkle slumber of God knows how many years. But I think we note with a little bit of concern that since 2016 onwards, the Tamil Nadu number seems to be a little bit stagnant and dipping down. So I think we need to pull up our socks over there, because we cannot afford to let the main engine slow down. Transport has been a big headache, for thoracic organ transplant. For what little work we have done, we've seen that private charter is through the roof. We've used it very little, once only. Commercial flights saves cost, but adds time. And perhaps, if I'm not mistaken, India is the only major transplanting country in the world which is liberally using commercial flights for organ donation. This is the last organ we had harvested, which is making a happy trip on an Indigo flight. And my friend Anway was telling me that they've harvested quite a few organs from in the outbacks of Maharashtra, which I think many people haven't known what kind of an animal an aeroplane is. So it's a tough job. Transport is still a rate limiting step in the transport in the transplant metabolism of India. The indifference of cardiologists sometimes achieves epical proportions. And I think we've got more work to do, probably joint meetings, joint papers. Somebody cleverer than me has got to work out how to liberate cardiologists from the seduction of the catheter. That is a tough job. We have about 250 plus annual trainees from both branches of MCH and DNB put together. I haven't really had the time to do a reasonably accurate survey, but somewhere the sixth sense will tell you that probably a little less than 5% would ever in their training lives would be acquainted with a practical hands-on heart failure program, leave alone having ever seen a transplant happen. So we have to be a prophet in our own land first. When great majority of our trainees are completely alien to a heart failure program.
Excuse me, sir.
Have the temerity to go and preach.
Excuse me, sir. I'm really sorry to interrupt, sir. We've crossed the time.
Resource consumption in various cardiac conditions has its own pattern. Whether you're considering acute MI, you are considering hypertension management, etc. And the resource management in a transplant program would fit somewhere over here. It's going to have a spike, and probably as the patient settles down, it'll have a high spike and then settle down over here. It is resource intensive if you consider individual interactions, individual patients, individual operations. But if you look at it holistically, then transplant and devices use less than 10% of the total, 2% of the total heart failure resource. And whether you transplant or you don't transplant, 30% of all healthcare resource in countries which are liberal with critical care are consumed in last 7 days of life. So transplant programs do not feel guilty, especially for the fact it's a given truth. It's a given truth in developed society that 30% of your all inpatient expenditure actually happens for the last week of your life.
Kunal, could I ask you to wind up?
Bala, once again in the Indian Journal, did a cost analysis of 160 heart transplants. He has very good insights. And the few points that I picked up from Bala's review was that he mentioned a 40% direct expenditure in terms of medicine and consumables, which definitely is more than accepted norms of around 25 to 30% as you have for non-transplant program. And what this complex chart, I think his paper is trying to tell us, the second chart is that longer the stay and for people who eventually do not make it, their cost-effective ratios are tremendously skewed. There has been a lot of erroneous reports regarding cost of transplants in the popular press, and I happen to pick up, and I think we have a duty, the society has a duty to correct these things. This is a smart graphic, but full of errors from the Times of India, which says that no government hospital has done a heart transplant. Now, how wrong can you be? I think I've just had an eyeballing estimate that at least 20 heart transplants per year happens in the government hospitals. We have a couple in Calcutta doing it. All India Institute does it, and they do it free of cost. So once again, there is a lot of garbage by way of graphic and infographics in the popular press that we need to get control of.
Kunal, could I please ask you to
burden in
wind up? I'll give you 2 more minutes to wind up.
They haven't really looked at transplants, but they've done a very introspective study on how the cost distribution happens when you treat heart failure. This is, I think, in the Indian Journal of Public Health. Basically, what they try to say is that they've been that it becomes expensive only in the sense that it is not the individual hospitalizations, which are tremendously expensive, but the repeated hospitalization and the need for repeated treatment that adds on quite a lot of cost, a recurring cost to this program. This kind of a program would obviously need government financial assistance, and that at best has been erratic. There has been generous governments like the governments of Tamil Nadu, Karnataka, Telangana, Gujarat, Kerala, who is variable. You know, it depends upon the mood of the chief minister, how much they want to support a program by how, I think it's a crying need for standardization. In West Bengal, of the few things we have done, we have 2 of our government hospitals who are doing a good job. And mind you, it's not only their clinical outcome, but they're doing it completely for free. So when we in a private hospital try to step into the transplant domain, you're actually competing with somebody who does this whole thing for free. But I think the bottom line is we need a standardized norm, which can be supervised by NGOs or NATO, to make these programs more effective. And health schemes, you see the spectrum, the horizon of healthcare in India, whatever happens to India, whichever party comes in power, one thing will be constant and all pervasive, and that is political populism. India will never get rid of political populism. And as long as you have populism, these health schemes will be there to stay. And they will consume more, and they will be eating more and more into the regular funded spectrum of patients, whether it is the national program, which is the state programs. So I think, rather than behaving like ostriches, that these catastrophically low-paying programs did not exist, we really have to get into and engage into dialogue, both at the state level and the central level, because there has to be a higher allocation within their visible spectrum. You should never feel guilty or ashamed to tell somebody that you are doing a transplant program, and transplant program has to figure in the annexure of these healthcare schemes with higher allocation for thoracic transplants with the scope of supplementary funding wherever the case may arise. So friends, a brief summary, I think this is too broad a topic for a stupid chap like me to try and summarize. I think we've done fairly well in recent years on standardizing brain death declaration. We've got to keep a close eye on that. Organ donation drive, especially after the mammoth distraction of the pandemic, we have to maintain it. We need measured growth. We don't need mindless mushrooming, where a center here or there just does a program to get a kick out of it. I don't think that is how the program survives. The leader states will have to maintain the lead. They will have to maintain their energy and the surge as the rest of the flap catches up, but the leader will have to continue to lead. And let's try and incorporate cardiologists in the program. Our own trainees will have to get familiarity with this program. There has to be meaningful role of government hospitals and standardized health schemes, fiscal assistance by state governments. And that, I think, should be a very constructive agenda for an association like ISOT. Thank you very much. Thank you for your patient hearing. And from Kolkata, wish you a next festive and a safe week ahead. Thank you so much. It's a privilege to be with you. Thank you.
Thank you very much, Colonel. Sake of time, we're going to dispense with the questions right now. I'll see if I can create some time at the end, and we'll move on with the second speaker, please. If Gokhale is there, I would ask the speakers to keep their chat box open on the side in case I can message you with timing so that we won't have an embarrassing cutoff of your slides, which we tried hard to avoid, but then you will lose your question time. Please introduce the next speaker, chairs.
The next event.
Hello, this is Dr. Chandrasekhar here, and I have great pleasure in introducing Dr. Gokhale, who is very well known for the transplant program in the country. He is from Hyderabad, and he did the first transplant in Hyderabad, and also he's a Padma Shri. Without much ado, over to Gokhale to talk to us on regulatory and corporate responsibilities. Dr. Gokhale, please.
Thank you, Chandu, and thank you, Kumud, and organizers of ISOT. Thank you, Dr. Jose, on behalf of Society for Heart Failure. I was asked to talk about a difficult topic. I'm not as fluent like Kunal, who can speak on anything. I was asked to talk about regulatory and corporate responsibilities in our setup in India. I thought I should include some of the responsibilities we also as professionals have got for this program. Now, the topics to be covered were responsibilities of various organizations involved in transplantations in India, status of equitable organ distribution, who is responsible for logistics, problems of unfair distribution, organ wastage, gaming, and poor practices. I will try to cover some of these things as far as possible. Now, as we all know, the ultimate organization and control of transplant program in this country has been handed over to the NOTO, National Organ and Tissue Transplant Organization. With the Transplant Act of Government in 2011, in its amendment, they said we need to establish a central organization to supervise the program throughout the country. It is now under the Directorate General of Health Services, Ministry of Health, and it is the apex center for all India activities of coordination and networking for procurement, distribution of organs and tissues, and registry of organs and tissue donation and transplantation in the country, in brief. Now, you see, in 2004, the amendment of the 2011 Act came and the rules were amended in 2014. It has been so clear, actually, till now, even I'm not aware of the whole responsibility of the NOTO. I have been complaining like many, saying that it doesn't have any responsibilities, etc., even though it was there. Now, this is considered an apex body, and it should work with the regional and state level networking organizations. And the state should be linked to the hospitals, tissue matching laboratories, tissue banks, and to the regional and national. So there is a flow chart, Noto, Roto, Soto. Now it should have a website that should be linked to a state or regional state centers, and the patient will be registered through that. And it's interesting to see that some of us have registered through Noto. All the people these days have to be registered with the Noto. Noto will give a unique number. And we also register our state organizations. Sometimes, because we don't get in our state, some of us, including me, have registered the patients in other states too. Like in Telangana, I register. And I also register a patient in Andhra Pradesh, because if there is a donor there in Apollo group, we can do it. But actually it is illegal. You can only register in only one state. And the allocation of the organs is to be decided by the state organization. And if it goes beyond the state, there's no taker, then the regional and the Noto will take care of this. Now the sequence of allocation of organs shall be like a state list, regional list, national list. And if there is no one, someone is coming from abroad, then the person of Indian origin, then foreigner. This is a flow in which we have to do that. And the online system of networking and framework and registry has to be, how it has to be maintained, what are the data to be collected. All the details are available, and the allocation criteria are done by state. They're state specific. They can be different from state to state. That freedom is there for the state organizations. And they should be finalized by the state government in consultation with the state level networking organizations. Of course, an exception is Armed Forces Medical Services, which doesn't come into this sort of thing. They have their own right from their group of hospitals. Now, this networking organization shall coordinate. Who coordinates all these things? The networking, state organization, regional, these things have to coordinate retrieval, storage, transportation, matching, allocation, all these things, and they as well as develop a standard operating procedures, protocols for such activities. And they should coordinate with the state government for establishing new transplant centers. And it's also nice to see that there shall be designated organ and tissue retrieval teams in state or district or institution as per requirement. That means not everyone has to go. There can be retrieval teams which can be found by the state organizations and which can help all the hospitals. And the network should be e-enabled. It should be on the net and accessible through a dedicated website. And the allocation criteria would be developed and modified as per the need. And it should also take care of the responsibility for education and communication of activities to the public and promote donations. And should maintain the registry. What registries? We'll see that. Anyway, the Noto has done part of this work. The Noto website was created with the help of a National Informatics Center too. But unfortunately, if anyone looks at that website, it is absolutely, as of now, doesn't serve any purpose. And it has to be linked to the regional center, state level centers. And the Noto registry was inaugurated in 2015. And so far, about 471 transplant centers, retrieval as well as transplant centers are registered with this. Of course, it has been happening the last few years. In the last 1.5 years, they claim that the numbers have gone up tremendously. And this website, people upload their waiting list, and every patient is allotted a number, as I mentioned, and then they can be registered in only one center at a time. Now, these are the registries we support to maintain. Organ transplant registry, donation registry, tissue registry, and pledge registry. All these things, it has to be maintained by the Noto. Now, it has done some work, as I mentioned. For example, it's not that we are totally independent in India. There have been organizations, the WHO, Global Observatory on Donation and Transplantation. It keeps pestering the Noto. I'm aware of it. They keep sending mails asking what is happening in the country. Why are you doing more live transplants? Why you are not promoting cadaver? What is happening to your patients? They keep getting bombarded. And these are the data presented by the Noto in 2018, recently 2013 to 18 data to this Global Observatory on Donation and Transplantation, a branch of WHO. Based on this, we can see that India does the maximum number of transplants next to the United States of America. It is very surprising to see that. For example, 2018, a total of 10,340 transplants are done. It is trying its best to maintain the registry, but there are certain difficulties it is facing, which we will see. Now, the same thing it is, for example, the number of donations, the number of heart transplants, lung transplants, all these data it is trying to collect at its best of its capacity. Now, as of now, there are 28 states and 8 union territories in India, and we have 5 ROTOs, regional centers, and 12 SOTOs. SOTOs are not represented in 19 states. They mean state level organizations. For example, Telangana has got a Jeevandan. It is a, health is a state subject. State governments pass their rules and they form their societies. And as of now, they are not following NOTO because the 2011 amendment has to be accepted by the state assemblies. Then they become SOTOs and they'll be funded. In fact, they'll be funded liberally by the central government. But for various reasons, the states are not taking this 2011 amendment to their assembly, and they are trying to work independently and not coordinate with the NOTO. Now, in fact, NOTO compares itself with the UNOS of the United States of America to some extent, in that there are certain commonalities. For example, it is also a non-profit organization. UNOS has got about 250 transplant centers. And in the last few years, NOTO has actually registered 471. As Kunal said, over a course of time, these numbers may come down because some will have a natural death, whereas some will keep doing more work. And our people also maintain waitlist registry, and then they maintain this registry in the website, even though it is not as transparent as in case of UNOS for the difficulties I mentioned, that states are not yet coordinating with the NOTO to give their data, to share what they are doing. And for example, if an organ is allotted to a place, they do not have time limits. And we have a lot of difficulties. We are wasting a lot of organs because of lack of coordination. Now, I was asked about equitable organ distribution. All are equal, but some are more equal. That is especially true in a country like India. Approximately 30% of the healthcare in India is funded by the government and 70% is out of pocket. And more than 50% of the healthcare in this country is provided by private institutions, especially tertiary level care. In fact, financial barriers are more prevalent than HB or HLA incompatible in India. So if you really want to make sure that the transplants are done even to the poor, irrespective of the finances, irrespective of the sex, irrespective of the region, religion, etc., like what you talk theoretically, then unless it is supported through public sector hospitals, at least one hospital in each state to start with, this can never happen, whatever we do it. What can this ever be done in a government hospital? The classical example, of course, is Institute of Kidney Disease and Research Center. You see in Ahmedabad, they are doing one of the largest number of kidney transplants, more than most of the private institutes. Very successfully, they are doing for free to the people. So they are showing that it can be done. I'm sure there is a will, there is a way. And you know how much we spend for our, our GDP for health? It's a peanuts, 1.3 to 1.4%, when other countries are doing anywhere from 10 to 17%. And we give a lot of free rations, etc., but only for election basis, but not really for the public. Now, there are organizations which are supporting transplant to some extent, like Chief Minister Fund, Prime Minister Fund, School Health Program, Aragasri schemes in Telangana and Andhra, and Mukhyamantri schemes. One of the most promising in our country probably would be Pradhan Mantri Jan Arogya Yojana. That is a scheme which is going to cover half of the population in this country. And I'm aware that a few of our members are working with the government to develop packages for heart transplant, lung transplant. If that comes out, at least half of the people are covered by that. And that would be a good way to push government hospitals at least to start with. NOTO also gives some funds, about 1,10,000 rupees towards drugs for per month if they are operated in a government hospital. Now, regarding organ wastage, in this country, while we are cribbing that there are not enough number of donors, we also have a problem that we are wasting organs and we are not able to mobilize enough. As you can see here, 875 donors, and there are hardly about 40% of them are being used for the heart and lungs. This is a slide prepared by Dr. Ravi Kumar, one of the few heart failure and transplant cardiologists in this country a few years back when we were trying to talk to the health minister. See, in these, about 40% are related to the marginal donors, 22% are due to the allotment issues, delays in allotment. You see, I'm aware of people who want to go and see the Argon and then decide after opening chest. Then how any other hospital can keep another person waiting, the team's going there, and if they say no in about half an hour to come back and do, all these things are only to give trouble to the people. And we also about 22% are wasted because of transport issues. And you know how to reduce this wastage? The most important thing is we need to have a proper coordination from the top to the bottom. One nation, one allocation policy. That is only possible if all the people who have got a lot of influence in their states work with their government and see that this 2011 Transplantation Act is passed in their assembly. Then you got a pyramidal system, Noto watching and trying to audit the system. And the other problem, of course, the donor management protocols. We are aware of so many donors where we cannot use the lungs, where we cannot use the heart because they don't monitor the CVP, invasive water line. They run noradrenaline like a tap. And you know, the distribution of these transplant centers is so varying. Unless all the states come forward, all the people cannot be helped. Now, what more can be done? Of course, we need a lot of help for transport. As Kunal was saying, we tend to use the private charter flights, which most people cannot afford. Of course, the government is working on green channels, and Kerala government is trying to provide free air transport. That is what I thought when I heard from Jose. And they need to promote air ambulances. And then like in Australia, probably these organizations can raise donations from philanthropies, from corporate social responsibilities, come forward to do it. We can make use of the Army and Navy support. And the late check-in for flights is absolutely essential. And the most important, of course, is how to push the government hospitals to do these transplants. And some of the things like a donor pledge form. In our country, if I want to donate, I give a form. It has no legal standing as of now. My relations can come and say, no, we don't want to donate. And the most important, the last is audit. Audit of counseling, brain death declaration, organ donation, utilization rate, transplant outcomes. See, in this, all of us have got the responsibility. We only claim that we are the second largest in the world in doing transplants. But when you ask for the results, whether it's a kidney, liver, or heart or lungs, we are nowhere. And we have a huge number of accident deaths. Potential donors, 410 people die every day. And what is that we are doing? Another issue that is being faced even by developed countries is gaming. Very interesting. For example, you want to help the serious patients. This has been noticed even by some people in our country. That is what I heard. Suppose you want to give a priority to someone who is an IABP. You want to give the priority to the transplant. You know, these heart allocation criteria have changed in UK and states. Once the IABP was given a priority, it has been noticed that some of these centers are assist devices have been given a priority. Some of the centers have started putting in more assist devices to put their patients in the waiting list, priority list. I mean, people are same, whether it's America, UK, or here. This is published in 2020 from the United States of America. Following the policy change, use of certain types of mechanical pumps increased up to 5 times. There is a notably greater use of these pumps among men following policy change, potentially giving them priority in the heart transplant list. And this is how, of course, human beings are, unless there is auditing, unless there is a supervising policy, things can never be done. So this is a big issue even in our country now. So what do? We have to make sure that from our side, we should participate in the national registry. For example, Indian Society for Heart and Lung Transplant started a registry, and Sandeep said he is breaking his head to get the numbers into that registry. I mean, we have a responsibility. Forget, see, we are improving. We are not comparing with anyone. But unless we have got our numbers, how can we ask the government to help us? There is a need for national standard operating procedures like brain death declaration, retrieval, packaging, labeling of organs, digital allocation algorithms, all these things. Unless we become the part of it, we do that, we can never become good. We can remain as the average or below average, but we can never be good. And we can see if we can share some common resources like XMO perfusion systems, including harvesting teams, professional bodies like INSHLT, Society for Heart Failure, Heart Failure Society of India. They need to take active role in decision making, work with the NOTO and state bodies. Should we have some targets and incentives to state and regional bodies to increase donations? Should we work on financial support for transplants? How do we promote brain death declaration? There are many problems. Of course, India is a gold mine. There is so much that can be done. If you look at that way, I think we all get energy instead of complaining. But let's accept that Noto, if not today, tomorrow or day after, it is going to be the leader, it is going to supervise, it is going to audit. Let us all do voluntarily instead of they saying that we will not give you a renewal of our license tomorrow. Why do we have to get into that? Let's try, be part of it and move along with it. See if we can make things better. Thank you very much.
Thank you very much, and a very timely closure there, Gokhale. Any questions, chairs? Any questions at all that you've got on your message boards?
Yeah, thank you, Kumud. And I think, Gokhale, you were talking about the role of government hospitals. And I'm sure if it comes to many, at least one hospital in each state, like you said, to take up the lead in transplant program. The problem with our government institutions, as you know, transplant, the surgical part is only a small part of it. And even in private hospitals, we find it difficult to do HLA matching, biopsies, reading biopsies. There are not many pathologists who can read biopsies. So these are issues, and even many private government hospitals, even doing a regular cabbage, they find it difficult because of the other logistic issues. How do you foresee that we can circumvent it and identify at least one center which can be promoted as a center of excellence in the public sector?
See, very good question, Chandu. As such, see, why is that Tamil Nadu is able to do it? Why is that Delhi is able to do it? Why is that Kerala is able to do it? Why not the other state governments are pushing it? It is the lethargy of the state government. It is probably the hand in glove between the private organizations and the state government that is actually killing the government hospitals. That is the first comment I would say. The second thing I would say is it's very easy, Chandu. In fact, if they have the mind, you don't have to worry about the surgeons. You have the people like you and me and many people who would like to spend a day or two in a government hospitals, and then who would help the government surgeons to do the transplants. To read a biopsy, if a government hospital sends a biopsy to any private corporate hospital, do you think they would refuse? They feel they are honored because these are not very common. See, if the government decides they want to do it, once the chief minister, whoever decides, or the head of the organization decides, things will fall in line. There is enough funding. Like you see, Nizams we have got here, Nizams have got enough funding to do a transplant. Arogyasri gives about 13 lakhs, which is more for a government hospital and less for a corporate hospital. There is enough to do a transplant. There is enough to give drugs for 1 year. So it is actually the leaders that are at fault. Where it is the government hospital, I wouldn't say the head of the unit or head of the hospital or head of the state government, if they have the vision, it can be done.
Very good. Any questions on your board?
That was a fantastic talk, Dr. Gokhale. It was a really, really nice talk.
Thank you, boss. Actually, yes.
Okay.
When you called me, my heart was in mouth when you said this is what Kumud was asking.
But you see, I've got a question for you, Gokhale. I mean, it's clear that the only way we're going to drive donation up, as you said, in a very open and frank talk that you've just given, is really to empower at least one public sector institution. And that's got to be a large academic public institution. But it seems that many corporates are very reluctant to do that. And one of this appears to be the fear that they're going to lose customers in volume. And I just don't see that. I think they will still maintain their paying customers, but there will be an enormous benefit in upskilling the public institute. What do you think, and how do we go about doing that? And what about in Telangana? What can you do in Telangana? For example, the corporates getting together with Nizam, for example.
Yeah. Actually, Kumud raised a valid point. We see, like a few years back, when a different government was there in Andhra Pradesh, I took government hospital of Guntur, where I studied and developed open heart surgery, did 4 heart transplants there. It's one of the few state-run hospitals in the whole country to do 4 heart transplants. We have done it. But once the government had changed and a few things have come, I left the whole thing. Even open heart surgery is not happening. And I've been trying to work with various people. For example, recently, I mean, I'm not supposed to say this, but I want to tell you that when you ask a question, for example, Nizams want to do it. I expressed my wish that I would like to support them if they want to do it. The head of the unit there, they have done heart transplant, and they have recently made me part of honorary faculty to help them to do a lung transplant, and in case of they require for heart transplant, they're open. I'm trying to do it. See, similarly in each state, I think we have to move forward. Don't expect only the government to do it. They have 1,000 problems. Doing transplant is the least. We have to talk to the concerned head of the unit. You say, I'm willing even to provide some funding for the transplant if they don't have enough funding. I think it is our responsibility to the society that we have come to this stage. We all need to spend some time, some money. I mean, you go and ask someone, CSR response, people are willing to give crores. If we are genuinely asking it, I think we have to do it. All of us have to, each state, some of us have to take the lead, try to go. It may be begging, but it's an honorary begging. You have to run around them 10 times. And people would ask, why do you have to beg? But I think it is our responsibility, unless the government hospitals do well in this country, it can never reach the bottom line. Working in Apollo, for example, Apollo said, yes, you go and help Nizams. I have no problem. You said corporates. And again, I was in another corporate which objected me in working in a government hospital. They're different. Mm-hmm. No? Yes. So, but there is a scope.
Yeah, but until that happens and there's some benefit seen in the public sector, I can't see the likes of NATO on a federal task to then come and place state-wise pathology services for us, because they will just be providing no more than a commercial facility from mainly the corporates. There'd be no benefit across on the public side. So that's a frustrating thing, and it's a bit of a catch-22. Are there any other questions there for Gokhale?
Just one last question. We were talking about the diseased organ program, but the organ donations haven't picked up in the last few years, like what Kunal pointed out in his slide. And I do not know the exact figure, how much of diseased organs we are getting from the government institutions, because most of the road accidents, the medical legal cases land up in government institutions because they need the postmortem, etc. So is there any way we can engage government institution not only to doing transplants, but to promote the diseased organ program, which could facilitate the organ donation?
Sindhu, basically, human nature is, if it is useful for me, I would promote it. If there is an extra, I don't mind sharing with others. Same with the government hospitals. Why would they promote donations when the corporate hospitals are doing it? And what is pushing? They say we don't have enough staff. We are already overburdened. Why do we have to do it? The NATO is going to give about $1 lakh, I think, for maintaining an organ donor, and plus transplant is done in a government hospital. It's giving some funds. But then they would never do it. The only way is teach them how to do transplants. Then they would run around, raise the donations. Once it starts, they cannot stop it. The surplus will come out. There will be plenty of surplus.
Dr. Gokhale, have you come across any of the SOTOs who have actually received money from NATO?
My state, see, this is what the NATO director says. See, at least I asked about transplant. Let me be frank. See, I said Tamil Nadu, is it a roto? But why do I see a lot of times it is under state government, etc.? Then the answer I got is only when the central government officials come, they put it as a roto. Rest of the time, they work like a state organization. See, we are a very democratic country. We are not going to punish people. Initially, we are trying to put these things. You know, in our country, we have all the rules. Implementation is a problem. But in a country like this, it takes decades, if not centuries. But still, it is one of the greatest democratic countries in the world. So we have to be patient. We have to keep pushing. We have to be patient.
Wonderful. Well, thank you very much. And on that note, I think we'll go with the next speaker. If the chairs could introduce, we've gained 5 minutes. Thank you, Gokhale. That's wonderful.
The next session is on collaboration and research. The speaker is Dr. S. Seth, and the chairpersons are Dr. J. Punnan and Dr. T. Meeran.
Isn't there one? Okay.
Good evening. I would like at the outset to thank Isot, Dr. Jose Chaco, and Dr. Kumar Dittal for giving me this opportunity to talk about collaboration and research in heart failure. Let us first look at the burden of heart failure in the world and in India. The prevalence of heart failure is about 1 to 2% in the general population and increases with advancing age. In India, we don't have so much data, but approximately 0.1 to 0.4% of patients are expected to have heart failure. If you look at the details of this breakup, we did a survey of the villages around Delhi in an area in Haryana, in a place called Vallabhgarh. We projected that we would expect to find about 1 in 100 patients as having heart failure based on the risk factors for heart failure of coronary artery disease, diabetes, rheumatic heart disease, hypertension. The actual prevalence that we found was from a population survey was about 1 in 1,000, which gives us an estimated prevalence of heart failure in India of about 10 million patients. When we looked at the patients who were being admitted to AIIMS with heart failure, we developed a rule of 3. This is from our FAR study. So we found that almost 1/3 of these patients were actually dying. It gives us a mortality of about 33%. Out of the patients who were being discharged and were being followed up for a period of 3 months, another 1/3 were being either readmitted or again dying. These are pretty sick patients when we get admitted. This data is quite similar to the kind of data which was published subsequently also from the Trivandrum Heart Failure Registry. Their 1-year mortality was about 30%, 3-year mortality of 45%. So on the whole, patients with heart failure in India are sick patients. Let's look at the management of heart failure. Well, we have lots of drugs for the management of heart failure. I won't go into that, from ACE inhibitors, beta blockers. Now more and more drugs are coming up. ARNI, then SGLT2 inhibitors, now maybe very Sigvat will be soon in the picture. There are lots of surgical therapies if drug therapy fails. But is it so simple? Again, if you look at the data which has been published from all over the centers in India, it's very easy to prescribe drug therapy. You can easily prescribe ACE inhibitors, you can easily prescribe beta blockers, you can say you're prescribing the drugs, you're prescribing diuretics also. But if you do an audit of what is being prescribed and what the patients are taking, or even whether are you prescribing the drugs properly, you find that the patients, only 30 to 70% of the patients are actually taking or are being prescribed ACE inhibitors or ARBs. 30 to 50% of the patients are on beta blockers, and only half to 100% of patients are on mineralocorticoid receptor antagonists. So the gap from evidence-based medicine to actually implementation of these medicines is quite tremendous. So we really need to do something to bridge this gap. Some of the initiatives which have been suggested are, we need to have quality improvement initiatives in ensuring that at the time when these patients are discharged from hospital, you have some kind of checklist to ensure that all the correct medicines are prescribed. You have some form of heart failure clinics for the sicker patients. Have a cadre of heart failure nurses who can help the doctors in the management of heart failure patients. Maybe have some kind of mobile apps. And since many of these patients are actually being treated by physicians and not cardiologists or heart failure specialists, we need to better train the physicians to manage the heart failure patients. Some of the solutions that we have successfully implemented at AIIMS are using heart failure checklists, which are started at the time the patient is admitted, starting from using correct appropriate uses of diuretics, choosing when to use a correct inotrope and when to initiate the use of a vasodilator, when and when not to use beta blockers. Then implementing simple checklists in the OPD, which are implemented by heart failure nurses, what we call the ABCD checklist: A for an ACE inhibitor, B for a beta blocker, D for a diuretic. Having an app, which is on Google Play Store called Dharkan, which allows us to link up with the patient, get the vitals, and if the patient doesn't want to use the app, a simple checklist, which we call a Hriday card, where all the checklists are on a piece of paper. We run heart failure clinic. We have talked about these heart failure clinics at various fora, and many of the hospitals around India are using a model similar to ours to run heart failure clinics, where we implement the various checklists. We have heart failure nurses there. We have rehab programs. We have heart failure nurses who give various forms of education to the patients. There are heart failure education booklets for the patients. We have rehab programs running. And these have been found to be effective. There's published data. On a national level, the Indian Council of Medical Research is now carrying out a national heart failure registry to pick up better data on heart failure in India. As far as education in heart failure is concerned, the Heart Failure Association of India has been running a regular series of webinars every month focused on various aspects of heart failure. Moving on from the medical management of heart failure, let's look at what is happening on the surgical management. The first heart transplant took place in 1967. The first heart transplant in India took place in 1968 actually. P.K. Sen did the first heart transplant in 1968. The patient did not survive. He did another one. The patient again did not survive. He was disheartened. He stopped doing transplants. Those were early days. Pulmonary artery hypertension was not known to be a significant prognostic factor as far as heart transplants were concerned. His patients had severe pulmonary artery hypertension. They possibly died of right heart failure. And what is known very well is that the first few transplants actually did not do very well. And the transplant program, that they started with a great deal of enthusiasm, actually stopped for some time. It's only later that when the Stanford group, who had actually developed the initial techniques, they kept doing research. The concept of endomyocardial biopsy, development of cyclosporin, and understanding the concept of rejection, infection. All that research ultimately led to improved 5-year and 10-year survival that the transplant programs actually build up to the current 10-year to 15-year survival of heart transplant patients. So focusing on the fact that it's not enough to just develop newer medical and surgical techniques. You have to focus on the research and developing the techniques to its fullest. India's transplant story continues. 1994, the first successful heart transplant takes place after the declaration of brain death program. This was published in the National Medical Journal of India. First heart-lung transplant by Dr. K.M. Cherian. Subsequently, we have some data coming in from Dr. Sundar's group on their experience with heart transplants, heart-lung transplants, lung transplants. And we find that, well, lung transplant patients are also doing well, 73% survival with 80% survival with primary pulmonary artery hypertension, lesser survival with ILD patients. Data from Sandeep Athabas to 80% 1 year of survival. I'm just trying this data basically to show that while we may not have a established registry, we do have individual data from various centers. And most of this data actually is really recent data. Looking at survival data from Dr. Bala's group, almost 75 to 80% survival at 80 months from a series published recently of 168 patients. Again, Dr. Atava's group, 55 patients, 2 years data, 3 patients died of sepsis, rest were doing well. This is our own data shows that you have to do a regular audit of what is happening to your patients. Before 2014, we were not doing too many transplants. We were doing 1, 2, 3 transplants every year. Organ donation in Northern India was not very high. From 2014 onwards, our transplant numbers picked up dramatically. But as the numbers picked up, the complication rates also picked up. We started having a number of infection, number of rejections, started losing patients also. So we did an audit of what was happening. We became very strict about the pre-transplant workups. We started becoming very strict about infection control. We relooked at all our protocols. We found that we were having a lot of fungal infection because there was a lot of construction around AIMS. So we changed all our protocols. We changed from fluconazole to voriconazole. We changed from acyclovir to higher degrees of drugs. We changed all our protocols. We trained a cadre of heart failure nurses. We also had more intensive care. We had a set of faculty who joined in as intensive care faculty. With that, in subsequent 2 years, our results improved. So if you look at the survival curves, 2014 to 16, the results improved, showing that an audit and then improving results requires a whole lot of care. But a lot needs to be done. The number of transplants being done in India is much lower than what we need and much lower than what the potential is there in terms of trained surgical and physician manpower who can actually do the transplants. There are a number of causes. I won't go into that. That is not the topic today, but organ donation is much less. There are very few centers who have high volumes. There are many centers who have very low volumes of doing transplants. It's not an affordable form of therapy. Many patients who need it cannot actually afford it. There are very few government centers. If there are more government centers, the transplant program can be more affordable. There is very little government support for these programs. So from that, let's move on to our first transplant registry. There was very little data which was published on transplants. So about 2-3 years ago, we set out to develop a transplant registry. This was a simple Google sheet, what we call Intran. So we listed the centers first. There were 72 centers involved with heart or heart-lung transplants. Based on that, on a voluntary basis, we just collected numbers. The first step was just to collect the numbers of how many procedures were being done. And this was published this year. So at the time of publication, we have 1,113 heart transplants listed as per the registry, 101 heart-lung, 338 lung, and 124 LVADs. This is the published data on a voluntary basis. So just a snapshot of some of the centers which have been listed in this registry. There could be some more, but this is a voluntary registry. So whatever all the centers are registered for this, we collect data based on that. This is not a very accurate map. This was actually made by one of the surgeons. So at the point when the data was still being entered, someone mapped the transplant data. But actually the kind of data that we need is data every year. So this is the kind of data which ISHLT publishes every year. They publish data on an annual basis. We only have total numbers, so we don't have numbers every year. We can't put this kind of data. Though we are now trying to request each center that if they can give us data broken up by year, then we can also plot out this kind of data. We also don't have the survival data for India. We have data published by different centers as series. We have our own series, we have Bala's series. These are individual series, but if we get survival data on an annual basis from different centers, we can probably merge the data. So this is an appeal to everyone who's listening. If you can get data like this, we have on the INSHLT WhatsApp group shared an Excel sheet which can be used to enter data on an annual basis. If that data is filled and shared with us, we can actually plot these kind of curves. We have tried to work with the Noto initially became quite enthusiastic that they would like to be involved in the data collection. So we had tried to modify and simplify the data collection charts as the kind of charts which ISHLT collects. So these are some charts we sent, but I have heard really from them as to what is happening after that from Noto. Going on to what else is happening. INSHLT has also this year started a fellowship in transplantation this year. They have selected one fellow who will go to Chennai, will be supported by INSHLT. They will spend 1 month in Chennai and be involved with one of the hospitals in heart transplantation. There are also multiple programs being run on various aspects of heart and lung transplantation by various societies in India. But there are still gaps that we need to fill. We must have official data. We have to have official data which is collected by either Noto or some of our transplant societies, and there should be more organized data. We have managed to get some numbers, at least that numbers are available, but we really need to do much more. There are individual series which are being published, which is better than what was maybe 5 years ago when even these series were not available. Beyond that, we should have multiple referral centers for heart failure care. This would allow rapid referral of patients with complicated heart failure, and they'll be able to refer to each other for advanced management, also for transplants and assist devices. We need to have better collaboration between public and private hospitals because each hospital excels in something. For instance, AIIMS could be excelling in excellent cardiac pathology, would have excellent transplant services, even though organ donation is not so much available. It would have expertise in teaching and research. Whereas centers in Chennai and Hyderabad have excellent surgical skills, they have access to organ donation, they have excellent surgical skills in heart and lung transplant. So they can collaborate with each other in terms of teaching and research. And some collaborations are going on and they can be increased quite a bit. There are lots of extended investigations that need to be done in many of these patients, like genetic testing, endometrial biopsies, and cardiac MRI, where collaboration between public and private sector is absolutely essential. And this can really improve the investigation and also cut down costs. Also, working in heart failure has to be academically and financially satisfying. Both in the government sector and in the private sector, both the surgeons and the physicians I have found are finding it sometimes quite difficult to work with heart failure, whether it's the transplant surgeon or the cardiologist working in heart failure. Both find it difficult. We have to really work hard to get the government to support these programs. The programs with heart failure, whether it's the transplant programs or the heart failure programs, have to be priced reasonably, but at the same time be economically viable. There are some initial attempts at developing indigenous technologies and collaboration with IIT. There are groups in Chennai. I think Dr. Bala, Dr. Kevala, both working with various groups to try and develop indigenous assist devices. I believe Dr. Cherian is also working with some groups. We also need to refer patients early for surgical therapy for heart failure. I think we are delaying the referrals for surgical therapy when the patient is too moribund. We have multiple groups who are using very little of endometrial biopsy and more of echo. This is the kind of data where we need to actually look at the data for this in a more systematic way and publish this. Most centers in India are doing this, but we have not in a systematic way proven that doing less of EM biopsies is scientifically correct. Most centers are using alternate drugs like basiliximab for induction, but again, are we correct in doing this? we lose more patients for infection. So again, we need to publish some data on the kind of infection that we see. Again, we need to get more support from the state and central governments and maybe try and push the transplant program into the Ayushman Bharat support packages. There are some attempts initially. Ayushman Bharat, the organization, has said that they would try to make packages for this, but so far it's a slow progress as far as this is concerned. So to conclude, heart failure in India is a major concern. It has high morbidity and mortality. There are lots of unmet needs. Medical care is suboptimal. Surgical care is not available everywhere, but wherever it's available, it's not fully availed. There are lots of novel solutions. You have to have heart failure clinics, heart failure nurses, you train more heart failure physicians and cardiologists. You need more programs in heart failure, both for the physicians and for the surgeons. You have to make these programs economically viable. You need more indigenous solutions, maybe mobile apps, better trained nurses, maybe even LVADs. And probably develop Indian guidelines, not just copied guidelines from the West, but practical Indian guidelines for the medical care and the surgical cares. I would like to acknowledge the inputs I've received from the Heart Failure Association and the Indian Society for Heart and Lung Transplantation on this. At the end, I would also like to invite everyone for the annual meeting of the Indian Society for Heart and Lung Transplantation, which takes place on the 26th and 28th of November. Thank you very much. Have a nice day.
Well, thank you very much. The floor is open for questions. The chairs may have some questions. And I just wanted to point out there was a little error in that we've skipped Jayan's talk for some reason, but we will go to his talk next. Thank him for his patience. Any questions?
Dr. Sandeep, I think you have done a phenomenal job in getting some form of a registry together. From your end, it's been a great effort, even though a lot of people haven't been contributing entirely to the registry, but that's a start. And hopefully we'll have a well-running registry in the next couple of years.
Thank you. Let's hope that we get better data by next year, because this was just to get some numbers and get everyone enthused by the fact that we can create a registry. And by next year, let's see if we can get some data on maybe transplant protocols or infections, because that is the easy part. And maybe at least get the past 3-4 years data on some kind of survival.
Yeah, unfortunately,
I think
last 2 years,
COVID.
Dr. Seth, could you, in the absence of others, hopefully there'll be some questions. I just wanted to ask you a bit more. I mean, if we can't get collaborative about data, it's going to be difficult to collaborate on lots of other things. And I wanted to know how, from where you stand, from an academic institution of great renown, how we can get around to creating research networks, collaborative ventures between institutions, or twinning of them, or even the networks, to do clinical and basic research and translational research.
I think,
and where would that money come from?
The first thing is to create a question. We have to decide what questions we want to answer. So that is the first thing. Like I put up some of the questions that we are doing much less of endomyocardial biopsies, and we depend on more on echo. So we decide that is the question. We decide on 3 team leaders and decide on how are we going to answer that question. Then we can figure out a way to create a research protocol and answer that question. That will not require too much of funds, but we have to have at least 3-4 teams who are willing to contribute patients to answer that question. But everyone has to be willing to contribute. But the problem is that if you look at the publications as showed, most of those publications have actually come out in the past 2 years. At the time when COVID suddenly came and everyone became free and they wanted to do something with their free time, they started writing papers. And not to complain, but I used to spend a lot of time with Bala and other people. I used to say, just scribble what you're doing on a piece of paper. I'll convert that paper into a proper paper. Because everyone is doing such phenomenal work. And each time I go to a meeting and I sit with everyone at the breakfast table, I say, you're doing such good work. Why don't you write that into a paper? It's only COVID that brought out those papers. All those series of survival data, all the data from Bala, Atawar, even Sundar has come out during the COVID time. And now moment COVID is over, all the publications will stop. I'm not complaining, but that is a reality. So actually, we need to encourage the younger fellows that, look, as part of your training, at least write one paper, not more, one paper. And let it be vetted by people who have written papers. At least in the academic institution, they're more than willing to help you write the papers. That is one. And at least do one research work, research protocol. And these questions can be answered. Like our experience with COVID as compared to the Western, we haven't lost so many patients. I've looked at the data from Spain, from Italy. The losses from COVID post-transplant have been phenomenal there. We haven't lost any patient. Like I haven't lost any patient post-COVID, either in the first wave or second wave. And I think all over India, we've lost some patients, but mostly we haven't lost patients. But we haven't documented this data properly. We've had one publication from our institute on post-transplant COVID that we managed to publish. But see, those are kind of things which we need to publish. It's not enough to write all this on a WhatsApp group that I've done this, I've done that. We should publish this. That is a small one step that we can do. Second thing is, as I said, that if we are using a lot of bacilleximab, where you're doing all these things, we can, even from a single institution, we can start writing this up. There's a lot of potential that we're doing. And all the expertise we have is in India. We really don't need to go outside India for any kind of training. Like from INSHLT, we started a fellowship also for training. That's a small step. Like we chosen one fellow this time. He'll come to Chennai. He'll spend a lot of time in Chennai. This is a small one, so it's a 1 month thing only, since there is no actual major funding for it. But he'll go around the hospital. So whenever a transplant takes place, he'll be involved in that. But that's a small step right now.
Yes, I mean, I couldn't agree with you more. We may differ on how much a month is worth in terms of a fellowship, but why is then the training, in the training program, as a structured training program, the involvement of research and having to write not mandated?
See, for instance, in the DM and MCH programs, it is mandated. Like in your MCH, you have to write a thesis. You have to write one research paper. That is part of it. It is a mandatory thing. So similarly, I think it has to become mandatory in some of with the other private sector transplant programs, that anyone who comes in as an observer, anyone who's there as a young fellow, the senior surgeon has to say that, look, if you have to work with me, you bring out at least one paper in 1 year or 2 years and give me one research idea which you will implement. Otherwise, you don't work with me. I think if Julius, I can only see Julius say. So if Julius says that, look, you want to work with me, you give me one research idea, write one paper for me. So that, I mean, you have to force it down through.
The trouble is, I think it's up for us to motivate and come up with the ideas, because some of them will come short. But that's wonderful. Listen, I have realized that Dr. Mulle has had some technical issues getting on. And so I wonder if I could ask him kindly to be an additional chair for this next talk that Jain Parmesar is going to give from the UK. And if I could get the chairs to introduce him, we'd carry straight on ahead. Thank you.
Thanks a lot, Kumud. I'll just try and get my slides up. Hang on a minute.
Meanwhile, I'll just introduce Dr. Jain Parmesar. He's a senior cardiologist at the Royal Papworth Hospital. He's been there since the last 25 years. He has very elegant and important body of work in the field of advanced heart failure and MCS programs. And he's a senior advisory member of various heart failure groups and bodies in the UK. He'll be presenting his talk on the Comparative Registry Act Before the Mandate, the Comprehensive Registry Act Before the Mandate. Dr. Parmesar, please.
Thank you, Dr. Hoti. I'll just try and bring up my slides. I opened them early and then I shut them down, so I'll just bring it up. Can you see them now?
Yeah, yes, we can.
Okay, I'll just try and get the slide view. Okay, thank you very much. And it's always a pleasure to wait for people like Dr. Seth. Any prof from AIMS for me is a big shot. I spent 3 years there doing my MD, so for me it's a great thing. And I think one of the reasons I went into the field I have is because of people like Dr. Emil Bhatia and Dr. Raj Tandon, who actually inspired me. So it's perfectly okay to wait. Okay, so my topic is to talk about the comprehensive registry. And the topic Kumud gave me was Act Before the Mandate. Kumud's supposed to be a friend of mine, so why he gave me this talk, I'm not quite sure. But anyway, we'll see. I think, you know, this is something which many people feel is boring because we all want to take care of patients. We want to operate or take care of the post-op patients. Data entry is something which nobody wants to think about. But it is actually very, very important. I'm going to try and talk from my perspective with the registries I have some experience with, mainly in the UK, plus also the ISHLT, and what sort of problems I have seen, but also how I think you can do better than we have done in countries like the UK. So why do we need these? So I've sort of tried to divide into 6 or 7 different topics what we can get out of a good, you know, registry. And these are not very separate. Many of them do merge, many of them do overlap. But I thought we can just look at it like this. So obviously, we look at activity. So this, for example, is an example from the UK, looking at the number of patients in ICUs who actually consent, or rather, a number of families who actually say yes to organ donation. And you can see over the years, you know, it's gradually gone up. Now it's nearly 80% in most parts of the country. But this is constantly looked at every year so that we can try and look at where it's falling, why is it falling, and so on. This is looking at what happens to these donors. So once somebody has said yes, and you can see for the various organs what happens. So if you're talking about the kidney, about 80% of the organs that are possible are actually used. When you take something like the heart, it's only about 1/5. And there are very many reasons for this, but it shows that there's a great opportunity. If we can push that curve up even a little bit, the number of donors that we get will go up hugely. And this is, you know, data that's produced every year showing how many people on the waiting list, plus how many transplants are done each year. And you can see the numbers aren't huge, but it's, you know, it hovers around about 180 a year plus pediatric, which will take it about to 200-ish. And the UK survival data, so you can see 10-year survival now will be just under about 68%, 67%. You've all seen the ISHLT data, and Dr. Seth has shown you some of that, you know, broken down to eras, and you know, this is the model on which we've all based our databases really. So you can look at whether it's era, you can look at what happens in those who survive 1 year, and you can look at things like what happens if you transplant from ECMO or long-term VAD. And you can look here, if you transplant from ECMO, your 1 year survival is going to be something like 70% or 75%. So that should make you think, should you actually do these or not? And you know, so this is the kind of way we can use this sort of data. So the other thing, of course, is to do various forms of audit. And this is an example of what we do in the UK. We look at all the centers. Now there are 6 adult heart transplant centers, 1 pediatric center. This is looking at the number of donor heart offers that the center declines. And you can see there's quite a lot of variability. So the higher you are on this thing, the more hearts that you're turning down. And I guess the way to use this is that if we think that if the center that's turning down most starts to come towards the one that's accepting the most, then the total number of transplants might go up a little bit at least. Similarly, we plot and publish every year within the centers the 30-day mortality, and you know, anything under 90%, people have to start thinking why. Similarly, you can look at 1 year survival, and you know, 1 year, this is 5 years survival, and again, you can see there is quite a lot of variability, and it's not to punish any center, but to make centers who are at the sort of bottom end of that, think about why they should be so much below the ones near the top. And of course, for the ones at the top, not to be happy and sit back, but try and keep doing what they've been doing. And this is another very interesting graph, and this is good because it looks like survival from the point you put patients on the list, not from the point of when you do the heart transplant. Because of course, if you're very, very cautious and accept only the best donors, then you will probably lose more patients on the waiting list, and this will fall. So you can see even here, there's quite a lot of variability between centers near the top and the bottom. Okay, so you can also benchmark countries rather than just centers. And if you look at the UK here, it's awful, isn't it? It's 2.8 heart transplants per million. Why should, for instance, a country like Slovakia be 3.8? Why should France, which is next door to the UK, be 6.5? We don't know. But it shows that something we are doing in the UK is very, very wrong. Comparing countries like the US is probably not worthwhile because their whole model is very different. A lot of their donors come from sources that we hope we won't have, you know, gunshot wounds to the head, the opioid epidemic and so on. But there's absolutely no reason why the UK should be half of France. Very similar countries, not far from each other. Dr. Seth has mentioned research and the need for us to publish what we're doing, and I would entirely echo his call for setting guidelines that are local. Having sat on many of the ICHD guideline committees and so on, a lot of them, the actual hard evidence on which they're based is small. A lot of the guidelines about, I don't know how many biopsies you do, is really a hangover from the late 70s and early 80s. And it is quite likely that if you change it now to doing more echoes and fewer biopsies, you might do perfectly well. So I think trying to look at your own data and setting local guidelines, I think is very, very important. So this is something we did about 10 years ago. We linked the Transplant Registry and the renal registry in the UK. We were looking at a big cohort of heart transplant patients and what happened to their renal function with time, which of course cyclosporin and so on are going to have an effect on. And you can see when you follow them down, you start with 1,600 adult heart transplants, and we follow them for years. You can see that by about year 6 or so is when the rate of renal replacement therapy starts going up, and it ends up at about 9 to 10% by year 10. And we actually did look at separate at the various adults heart transplant units as well. It did vary quite a lot actually, from 6 to 7% in the better units to 11% to 12% in the worse units. And we also looked at what happened when patients were on the dialysis, and contrary to what we expected, the actual survival on the dialysis over about a 5-year period was very similar to the national dialysis population of the same sort of age. So it's just a small example of how, if you had good data, you can look at these things and really give your patient a realistic idea of what they can expect from a heart transplant. What about looking at things like organ allocation? Well, this is something we did fairly recently. So until 2016 in the UK, we only had 2 tiers. We had a non-urgent tier, and then we had an urgent tier. But of course, the urgent tier consisted of a whole lot of patients, not all of whom were equally ill. So in 2016, October, we introduced a so-called super urgent tier. And this was essentially people on temporary short-term MCS. So this were things like Centrimac, BiVADs, and ECMO only. And what we wanted to do was, after 18 months of the new tier being used, we wanted to see what the effect was, and did it have the effect that we wanted. And in fact, it seemed to. So after 18 months, we found that the super urgent patients, their median waiting time was about 9 days. The urgent was 52, and the non-urgent, you can see, was 500. But essentially, the most ill patients seemed to be getting the hearts fastest. But of course, we wanted to make sure that that wasn't at the expense of a worse 30-day survival. Unfortunately, it wasn't. So whether you were on the super urgent list, or the non-urgent list, the 30-day survival wasn't too far apart. Okay, another very useful tool for some people anyway is the ability to regulate centers. And I appreciate that this is a topic that can be viewed in two ways. There are some people who feel that they don't want to be told what to do. They don't want to be regulated because it'll make them risk averse. But, you know, when we are looking after, you know, heart and lung transplant patients, we are not just looking after the patients, we are also, you know, responsible for good use of that donor heart or lung. So I think it's important that we make sure that whatever organs we get, we use wisely. So one of the tools we use in the UK is something called the Cusum chart, which I'm sure many of you have seen. It's a cumulative sum control chart. It's a tool that came out of Cambridge University a while ago. And the one we use more is the so-called Tabulated Qsym. So it uses the observed mortality versus the expected values. And it's a way of trying to see if there's been a significant change in the underlying mortality rate for a center over a period of time. It gives you a sort of an early warning sign, if you like, that something is going wrong, so that it gives the center and the team a chance to look at what is happening, just like Dr. Seth showed us when they show, you know, when he had a higher mortality, they were able to go back, change their protocols, and of course things improved. And that's exactly what the Tabulated Qsym is meant to do. So this is, you know, just an illustration. So here, every upswing on this chart is a patient dying, and the downswings are multiple. So each upswing is higher, if you like. You lose more when a patient dies than you gain when a patient lives, because you expect the patient to live. So you can see that over time, somewhere around 120 transplants, you start getting this spike, more and more patients dying. And we're coming quite near this line. So that line shows when any kind of central regulatory authority would intervene and say, look, guys, you need to have a look at what you're doing, and actually sometimes send in a team to help them, which is one of the roles I've had in the UK over the last 3 or 4 years. And the idea is not to punish a center. The idea is to try and see whether we can help them to think better, whether we can make sure that the risk profile of their patients is appropriate, whether their protocols are right, whether they're doing something wrong that can be easily set right. And you can see here in this center, they've done something right. And over a period of time, between 150 transplant and about 220, the outcomes improve a lot. And then you see a spike again with time. And this is what happens to most units. It may be that, you know, when you're doing well, you start doing higher risk patients, or a unit may lose and very experienced or 1 or 2 experienced members of staff, and new people come in and have got a sort of learning curve. So various things can happen. But this is a way for any sort of, you know, regulatory body to look at what a center is doing and intervene before too much harm is done, if you like. And I said, this informs transplant units about how their outcomes are changing over time, and it facilitates central oversight. And it enables prompt action. You don't want to wait too long. In fact, what we do at our centers, we monitor our own Qsym, so that long before anyone externally tells us what's happening, we should know. And we can start looking at, is there a good reason why we've lost more patients than we ought to? And then we can go back and try and put that right if we do find anything. So people like Dr. Gokhale have already made quite a lot of the case that I was going to talk about. You know, I think it is really important that India's at a good time now. I think I'm optimistic, a bit like my friend Bala is. I think India's numbers will go up, whether it's immediate or over the medium term. India is going to become, I think, one of the major heart transplant countries in the world. And this is the time, as Dr. Seth has said, to come together, collect data, and produce data that is specific to India, but also that you can share with the world. I think you should think very hard about what data you want, because the problems that, say, we have in a country like the UK at the moment is that a lot of things we would like to have to analyze, we don't have. And when we say we want to change what's been collected, there's a lot of barriers in terms of money and IT time and so on and so forth. So I think try and get it right from the outset, right from the outset. The more data fields you put in, the harder work it is going to be. That is true. So you may think about whether you have a basic data set that is mandated that everybody's got to put in, and then a secondary data set that is not mandated, but it'll be nice to have. That's not ideal. It's better if everyone can put everything in, because then it makes your data set much more powerful. But one has got to be practical, and say it's better to get some data than to get no data. Who's going to fund the database? That's hard. As we've heard earlier, health is devolved to the states. So the interaction between the central body and the state body has got to be worked out. And of course, will the funding body have the power to actually regulate? I think it is only useful to have a comprehensive national registry if data entry is mandatory. It can't be that people have a choice. You can't say they can put in data if they want, obviously. People can't cherry pick and put in things they want and leave out things that they don't want. And ideally, there should be some way of verifying the accuracy of the data. That's not easy, I know, but it is actually important, I think, in the long run, if you're going to produce good work, good papers that will show the world what is going on in India over the next 5 to 10 years. So I think I'll stop at that point and give you time to discuss this further. I accept that I'm talking from the perspective of somebody who's not in India at the moment, but I think I'm really excited by what is going on in India. And I know I've been fortunate enough to be able to interact with many of you over the years. And I think there's a great opportunity to do things well now. Thank you.
Jain, thank you so much for that absolutely comprehensive discussion. Chairs, over to you for questions.
Thank you, Dr. Jain. It was an excellent talk, and I am sure it answered a lot of issues and questions that Dr. Seth highlighted in his talk, and it gave a lot of ideas about how we should be able to improve the data entry and registries in India. And I have one small question. In one of the last few slides of mandated registries, you mentioned that a two-tier data entry system can be thought of. So can you just briefly elaborate what exactly would that be?
So it's not ideal, but for instance, the ISHLT, not every country puts in all the data. Okay, so because there are a huge number of data fields, some people will say we haven't got the money or the time to put so many data fields in. You might say, what is the minimum data set that every center has to put? Obviously, you'll put things like name, age, sex, survival, and so on. But ideally, you want everything, isn't it? You should have the patient's, the pre-op renal function, the pulmonary vascular resistance. You want the cold ischemic time, warm ischemic time. The more data you have, the more powerful that set is actually going to be. But if people say we just can't do it because we haven't got the time or the money to pay somebody to actually do this, then maybe you got to sit and say, okay, what of all these things which we would ideally like, which ones are absolutely must, and which ones are, nice to have, but we can do without. So that is a pragmatic thing depending on funding, and because every hospital who's putting in data will have to actually, pay somebody to do this, isn't it? And it is, and believe me, it's not a problem that we have licked in the UK. We have huge problems with that data set, and we spend a lot of time going every year when they actually circulate every year what we put in, and you'll be surprised. There'll be 10 patients who've had BIVABs not in the thing, completely missed. So someone quite senior then has to go and sit with the data entry person, check why it's not done. If you just leave it to any sort of data entry person, because they don't understand why this is so sort of important, they may just make a mistake. So I think it's a big problem we have had, and I think it's really important to think when you start, who's going to put in the data. I have a feeling it'll be better done in India once you set it up, because you have a good, quite a well-educated technical workforce, which will work for a reasonable amount of money. You don't have to spend a fortune. In the UK, as you know, when we want to do anything here with IT, we have to get someone from India. You know, if I pick up the phone and say my TV is not working, the person who talks to me is not in the UK. He or she is always in India. So, you know, I think this you have to think about. How much data do you want? Absolutely, the more you get, the better. But can you do it?
Just one more a little question from my side. Since we all know that we are struggling with the organ donation rate in India, especially in relation to the heart, in one of your initial few graphs, I must acknowledge that all the graphs are very interesting and very enlightening, and they really told us how we should go about doing these things in terms of data collection. You know, the initial few graphs you mentioned that some of the centers, some of the hospitals are showing donation rates of about 40%. I mean, conversion rates of about 40%. So in terms of audit, is there something that a regulatory body would do in order to, let's say, I mean, pardon my using the word, pull them up in terms of conversion rate or something like that?
They don't actually penalize you, but what we try is to have sort of national meetings where we have sent or people from all the centers. And what we're trying to do, this is something we're just trying to do now, is to say, put up a donor and say, okay, this is a donor, which 2 centers have turned down saying heart function is poor, but another center has taken it and actually implanted it. So try and get the surgeons who turned it down to say, why did they turn it down? You know, why did you think it wasn't good? And for the center that has put it in to say why they thought it's good. So, you know, to try and learn from each other. A lot of it is experience of the surgeon. So I think I can say this in this forum. Our biggest problem in the UK is getting interested cardiac surgeons, okay? We have the opposite problem to what you have in India. Cardiologists, we got plenty, a lot of good ones. Surgeons, really difficult, okay? They don't want to do it. Because some people like Kumuthi used to do it and now in India, so.
Thank you.
Thank you, Dr. Jain. Just a small question. It's a wonderful talk. I want it to be relevant to focus on a particular aspect each year in the registry, especially when you think that the entire, initially the entire data cannot be entered. Focus on a particular aspect each year, add on, after the basic concepts.
That is possible, but most of our data sets, you know, as you know, we need longitudinal data, don't we? You know what I mean? We need, so I think if we do topics for 1 year, you can focus on a topic to analyze each year. But if you focus on a topic to or a field to enter data, the problem is you'll get only a point data set. So say if you're looking at, you know, renal function, if you do 1 year, the problem is for most of us, what we need is what is happening to renal function over time. What is happening at 1 year, 2 years, 5 years, 10 years, isn't it? So that's why I think we need those. I don't think you can focus on. I think you need to have longitudinal, but it may be that we can't do everything. And we just have to say, if every center can put I don't know how many fields people think is acceptable, because, you know, you can go on and on and on. You can have 500 fields quite easily, but then it'll be too hard. But if you can get 50 fields or 100 fields or something which everyone can sit and agree that can be done, it's not too taxing to do. Because most of these things, people have the data. It's just someone putting it in. And of course, the hardest thing is to go back and put data that is missing. That is really hard. So you have to do it from the beginning. So it's identifying what is possible and then trying to do that, I think.
I just two couple of comments and one question.
Yes,
it's an excellent talk. I enjoyed your talk. And the database is something which is very close to my heart. In India, it is difficult. I know I was grown up for 10 years in UK, and I know the importance of database and working together. What I look at it as, we should database when it comes to in India, what we feel is that, no, why should I give my data? But it is my personal thing. And why should I tell my mortality or something like that? But then nobody wants to, everybody wants to learn from their own mistakes and their own problems. I'm not saying totally mistakes, no problem, but they are not willing to come out and then discuss with others and come out with it. So it is not who is the problem, it is what is the problem. And if the surgeons identify it, then it will be easy to give the data of ours and then understand. The second thing is that what Milind was also saying is that in India, the number of centers which have been licensed to do the heart transplant or are phenomenal. Like every couple of months, I'm seeing one center in Maharashtra which is coming up for a license to do a heart transplant. Now, what happens with that is that, again, the collection of the database is going to be difficult. The training of the staff, not only one surgeon, but whole team, it's a whole team, including the paramedics, including the retrieval team, including the transplant, everybody is going to be difficult. So if at all we identify, or the government or the licensing authority identify 1 or 2 or maximum 3 centers in each state, the collection of the database will also be easy.
Yeah, I agree.
If they overcome that, if they are saturated, if they cannot cope up with the work they are doing, then yes, open the 4th center. You have trained staff, you have the trained surgeons, you have trained cardiologists, everybody all together. And it is not one person's job. No. So you have to lead the development of the whole team.
Correct.
That is the second thing. The third question, the question which I felt was to ask, was confused, was you showed me two slides in which one you have said that the people on ECMO or Centromag, temporary LVAD, who undergo the transplant, the 30-day mortality is as good as compared to the urgent, supra-urgent, or means the supra-urgent, urgent, and the regular list. The mortality, the 30-day mortality is the same. But the patient who was on ECMO or a temporary LVAD, the 5-year survival of them is little down as compared to the other normal. But the patient in front of me who is on ECMO or on LVAD, who temporary LVAD, who is dying in front of me in, if he doesn't get a heart, because at my center, by which I have published the data, that the patients who had undergone a transplant after the LVAD, they are still living. And there's a 100% survival as against 100% death if they do not get the heart transplant.
Yeah. So so those two slides. One was from the ISHLT, which showed the ECMO survival was poorer. The other one was the UK data, which only showed the 30-day mortality, and that was a combination of ECMO and BiBAD. But actually, it is mainly BiBAD, very few ECMO. Okay. So me personally, in my center, I would rarely advocate transplanting from ECMO. And the reason for that is because we almost never have enough time. The number of days we can support well on ECMO is always limited, isn't it? And whereas BiBAD, we are quite good at supporting for many, many weeks, even months. And outcomes from BiBAD, for those who get on the list, is much better. What happens with centers doing ECMO, because they know that they can't wait too long, I think they tend to list too early. What I mean is when the patient is not fit for a heart transplant yet, they haven't recovered liver function, kidney function, and so on. And then you're operating at a time when the actual risk is higher, right? Yes. And that's what happens. France went through this many years ago. They gave high priority to those on ECMO. Their 1-year survival fell hugely, So because people were transplanting at a time when I think it was too early. With BiBADs, I think you have enough time to get them fit and hold them, at least a reasonable time. And then I think the outcomes, I entirely agree with you, the outcomes for those people are actually very good.
Excellent. So sorry, Jain, I wonder if I could bring you back to the registry and to ask you, in the UK, the funding, is that always been central? And a second question, for example, at the Royal Papworth, how many are involved in the whole business of data collection, data entry? And finally, how does the UK police the veracity of data that's been entered?
Okay, so NHS Blood and Transplant, which is one of the regulatory bodies, hosts the database. NHS England in England and NHS Scotland actually fund the heart transplant units to work. NHS Blood and Transplant only funds the donor end of it, So there's no, it's not like they give you funding for the database, but when the unit calculates its costs, it should say, we are going to need so much of a person's time. So in effect, we have one data entry person. We have some of the transplant coordinators who will help that person. But what we have found recently is that the transplant cardiologists have to, at least once in 6 months, go through this data that this data entry person is doing, because the check on it is an NHSBT stats people go through this and send us an email. So I've told them that the transplant cardiologists have to send the email, okay? Because hate to say this, sending an email to a transplant surgeon in the UK is like a black box. Yeah.
Yes.
It doesn't come out, right?
And policing, how do you police data?
So policing of whether it's whether the data is accurate.
Yes.
So you have to put in data, otherwise you don't get paid for your VAT. Okay, if you haven't sent in your data return and you charge them for VAT. So when you charge NHS England, or when you say we have done 5 BIVADs, they will look at the NHSBT database. If those 5 LVADs are not, or BIVADs are not there, you won't get paid.
Yeah.
Right. So you have to put that data in, and therefore, so there's a check. Now, is somebody checking every serum creatinine or bilirubin? No, that's not feasible. But at least broadly, you can't not put patients in, otherwise you won't get paid.
Yeah. Wonderful. Jain, thank you so much for that. And lots of question time, which is very useful. And to the chairs for the
By the way, I just said if anyone does want some of those slides, we're welcome to have them. They're not personal ones.
That's great, Jain. That's wonderful.
If you want, just send me an email or something. That's fine.
Very kind. Could I ask the chairs, please, to present the next speaker?
Our next talk is on Are We Failing Our Trainees? Perspective from Above. The chairperson is Brigadier Dr. S. Kumar and speaker is Dr. B. Iran. Over to you, sir.
Can we start?
Yes, sir.
Okay. Thank you very much for inviting me to give this talk. I don't know how this talk has featured in this session of the transplant program. The topic given to me is, are we failing our trainees? Perspective from the slopes. Well, I was wondering why.
Excuse me, sir. I'm just interfering for a moment, sir. The presentation hasn't been sent, sir.
Yeah. So I'm just sharing the screen. Will it come?
Yes, if you.
The screen, sir.
Yeah. I'm trying to. I already.
I'm sorry, sir. It's not visible, sir.
Not visible still. Let me see. Because I shared the screen and I don't know why it is not coming. But nowhere on the screen it shows that I had to share the screen somewhere.
At the bottom of your Zoom.
Excuse me, sir. Sir, you need to open the presentation and press on the screen share, sir.
That one, all right.
No message coming back saying you don't have
nothing coming now.
I'm really sorry for the inconvenience.
Nothing, no message coming now.
Dr. Balram, is your talk already open on your computer?
Yeah, it is open.
It is open.
It is open.
Recording in progress.
To swap around, and I could go first and give you time, maybe with the technicians, to work it out.
Or is it okay if I can just go through my slides, because there are no graphs or the pictures in that one, and I can give my talk?
Okay, sure. Why don't we do that?
Is it okay?
There's nothing there apart from writing that you want to go through?
That's right.
Okay, well, go ahead. We'll listen to you as a lecture. Wonderful.
Okay, thank you very much. I'm sorry that you can't see the slides. First of all, I'd like to thank the organizers for inviting me to give this talk. And the talk was on, are we failing our trainees? Perspectives from the slopes. Why this talk has come? Maybe because if you see all over India, there is a paucity of the trainees in the cardiac CTVS program. And I'll come to my next slide, which will tell you that what is the picture today. Because less than 50% of the available seats are nowadays occupied by our trainees. Why it has happened so? Because I think our medical graduates, they are very less interested in the surgical disciplines, more so in the cardiothoracic surgery. Why it has come over the years like that? Because it used to be a charming and a glamorous career in cardiothoracic and vascular surgery. So why we have come to this point, that is what I am going to ponder over, and whether we have got any solutions to all these problems. Now, the main assignment given to me was that what is the current trajectory from MBBS to consultant CTVS or the transplant surgeon? Second, what is the training program for the specialty and the fellowships? How many seats are available and why these are underscribed? Also, curriculum and examination. Do we need a change? What does the training aim to produce and does it reflect in the product? How much does the trainee actually learn, whether it is theoretical or the practical, during his training program? Whether we need to have a look into our logbook or structured training program, what is the timeline and the expectations, and what does in the end the trainee wants, and what are the solutions thereof. So I'm not exactly going point-wise on all these aspects. This is a reflection of my own journey of about 40 years of the academic career in this field. And some of the inputs are from my trainees and some from my colleagues. Now, how many training institutes are there in India and how many seats are available? There are various programs. MCS program in CTVS, which is conducted by NEET. Under that heading, there are 53 institutes and 169 seats are available. AIMS Delhi has 32 seats, out of which 3 are sponsored and 29 are open seats. Other 6 AIMS have got 14 seats. Then we have got DNB program, which is conducted by National Board of Examinations. Under that, there are 3-year courses where 11 institutes participate and seats are 20. Then there is 6 years program where 24 institutes are there and there are 61 seats. So overall, there are 95 seats and 95 institutions and available seats are 296. Now, if you see the enrollment, then in the last session of July 2021, all the 6 AIMS plus AIMS Delhi advertised 16 seats, 16, and enrollment was only 1. That is quite dismal. In fact, this is the first time that in AIMS Delhi, the seats are not full. So why it is so? Let us see. The main challenge to our residents are that there is long incubation period. By the time a trainee gets his MCS or DNB degree, the minimum time which he has to spend is about 12 years. Even then, he is not a fully qualified CTVS surgeon. He has to go through the further training to be self-sufficient, to be confident, mature, and to make the decisions. So this becomes a very long incubation period. Throughout his training, he has to undergo very, very hard work, strenuous work, which affects his mentality also. And nowadays, in the current generation, the dictum is less work, more pay. So naturally, all these young minds, they go for the other disciplines. Now, if you become a cardiac surgeon, say, and if you want, it is always a teamwork. An individual cannot carry out the whole work. So he has to have very costly setup in terms of the equipment, staff, and then the consumables, which are very costly. So it is not possible for each and every While selecting the trainees, we should always judge their level of intelligence, their aptitude towards this specialty, their interest in this specialty, and their attitude that we had to learn at all the costs. They should be asked why they want to become the cardiothoracic surgeon, who inspired them, and whether they have got the capability to judge, to make a decision, and to be a leader in this field. Even then we'll get the good candidates. If we get the good candidates, we'll have the good cardiothoracic and vascular surgeon, which will be carrying the good results in the long run. Changing in our curriculum, how to attract the young minds to this specialty. At the MBBS level, we have to request the authorities to expose these young minds to this specialty by hosting them, particularly in our discipline. During their hosting, maybe they should be taken to the wet labs or the simulation lab to tell them what is cardiothoracic surgery. Maybe they should be given the opportunity to watch the operations in the operation theater so that they will be interested in this field. I know that I never wanted to be a cardiothoracic surgeon till the time I had to undergo for the mandatory house job in cardiothoracic and vascular surgery. And mind you, within a month, the specialty looked so charming to me that leave aside being a surgeon, I wanted to be only a cardiothoracic surgeon. So that's how we can initiate these young minds into our specialty. During their rotation, during their Masters of Surgery, they get about 1.5 months to 2 months rotation in the CTVS. During this time, they should be much more exposed to the operating room for the pre-op and post-operative management of the patients so that they will know what there is in this specialty. When I was at the helm of the affairs at AIIMS, all these residents, I used to put them in the operating room. I never exposed them to the paperwork in the wards because that I thought was just the wastage of time for these young minds. And many of these fellows we could inculcate to get into the MCS program. For the MCS program, we had to revise our curriculum, discard the redundant syllabus from our curriculum. Even now, much of the time is spent in teaching these fellows what is our past history, how the fields were developed. Now this specialty has grown up so much that we should include the hot topics like minimally invasive cardiac surgery, like surgical treatment of the end-stage heart failure, the pediatric cardiac surgery, you can say the endovascular interventions, catheter wire skills in the cath lab, and etc. So that the people are much more interested in these fields, and this way they can compete with their allied specialists also. Also, in the logbook, nowadays what happens in the logbook, they will just enter the name of the patient, what surgery they have undergone, what was their role as a first or the second assistant. That is not the way. We should have the comprehensive short note on the particular patient, that what was the pre-operative condition, what was the final diagnosis, what was the intraoperative diagnosis, what exactly was done, and what was the post-operative period like. And then maybe, if possible, the follow-up also. This way, the patient, the trainee will be much more interested in that patient. They should be asked to write down the operation notes of the patient which they have assisted, including what was the position of the patient, draping of the patient, what instruments were used, what sutures were used, what technique was used. When I was a resident, by evening of the same day, I was supposed to write down the detailed notes. And my mentor, Professor Gopinath or Professor Venugopal, they used to check each and every word, whether this was 3-0 suture, 4-0 suture, whether it was backhand bite, forehand bite. And once we are in the process of writing down the detailed operation notes, it will be completely absorbed in our minds. Then we don't have to think twice, because everyone is not going to work in a fully functional unit when they go out after their training. some of them may have to set up their own program, and it will help them during that phase, so that they will have to guide the nurses, they will have to guide the perfusionists, they will have to guide the anesthetists, that what exactly is required. Examination pattern, it needs to be changed. Besides judging their theoretical and the practical aspects, we should know what is their judgment level, what is their decision-making process, what is the overall post-operative management, what is their human approach towards the patient, so that when they complete their training, they should be fully confident surgeon. They should be able to take a decision. Their judgment should be okay. They should have the leadership quality. But unfortunately, in India, there are only a very few centers who is fully equipped to train these young minds along this pattern. And even if the center is fully equipped, because of the lack of time or because of the no interest by the mentor, they are not able to do so in most of the centers. Now we have got the 3 years program, we have got the 6 years program. Both are good. But I think in the 3 years program, when the fellows are coming after the Masters of Surgery, those 3 years are almost wastage. Because how many of us go back and do the general surgery? I think 1 year program is okay for the general surgery to know the basic surgical principles. Rest of the times, like in the 6 years course, we should spend in our own discipline, or we should post them for a reasonable period of time in the allied specialties like cardiology, cardiac anesthesia, cardiac radiology, pediatric cardiology, and then nuclear medicine, cardiac pathology, so that they can imbibe whatever is relevant to our specialty from all the allied specialties, so that they will have the comprehensive knowledge of the subject. Yes, like in the 6 years course, there is exit exam after 2 years and 5 years, that is excellent. And in the 6 years, they can hone their surgical skills. However, there is a drawback to that, that if we enroll these young minds just after their MBBS, many of them, they don't know what exactly discipline they want to follow. Like we were the first one to start the 6 years program at AIMS. We had to discard this program because what used to happen, we were getting very, very inferior quality residents who used to think that once you get into this program, your 6 years are secured. You will get the definite pay. And for 6 years, nobody can check you out. So the material which came for the training was of very, very low standard. So that needs to be screened out properly. What is the role of the wet labs, simulation labs? Well, the wet labs and simulation labs are fantastic. They will tell the candidate what exactly the procedure details. However, these labs cannot replace the hand-on training program. Hand-on training program is must. Unless until the candidate operates himself, he will not know all the nuances of the surgery. And for this, the mentors are responsible. Whenever these residents are given a surgical procedure to take care of, the mentor himself should be the first assistant so that he can guide them properly. Many of the institutes, they will just allot the case to this training and leave it to this senior person at the resident level to guide them. That is not the way. Unless until the mentor himself takes the pains, the resident will not be able to know all the finances of the surgical skills. If the mentor doesn't have time, better he should not opt for a training. He should pass it on to the next person who is interested in training. I know that there are some operations which cannot be given to the residents, but however, in a stepwise manner, from simple to the complex cases, by the time the resident passes out, he should have done a reasonable number of the patients himself. Also, after the MCH is over, the things doesn't finish there. We should start the fellowship programs, like some of the institutions have got the aortic fellowship, pediatric cardiac surgical fellowship, CABG fellowship. So that may be for 1 year or 2 years, but that gives the time to these fresh MCS pass outs to settle down, to make them more confident, to hone their surgical skills. At the same time, they are financially supported.
Dr. Iron, I wonder if I could ask you to wind up so we can at least have some minutes of question time.
Sure. So only thing was that now only 1 or 2 slides are left. One is how to increase job opportunities and increase financial gains. Well, if the product is good, it will be sellable in the market and finances will automatically come. That means that we should train a person who is fully mature, confident to operate so that he is ready to plunge in the market. All of you know that training in the medical disciplines and surgical disciplines are different. Surgical disciplines training is much more rigorous, and the mentor has to take the full interest in the candidate. Also, we should cut down the workload on the trainees. Nowadays, the trainees are overloaded. In the private sector, because of the financial concerns. In the public sector, because of the too much of the patient load. We should trifurcate our specialty because the specialty has grown too much into cardiac, thoracic, and peripheral vascular surgery. Some of the institutes have these specialties in different fields. As I said, increase the fellowship courses. And lastly, we should interact and collaborate with the centers of excellence in India and abroad. Because none of the centers are have the expertise in all these fields of the cardiothoracic and vascular surgery. Pinpoint the centers which are excellent in one or the other fields. Collaborate with them, exchange the students with them for a particular period of time so that the students are exposed in all the fields and they are experts in all the fields by the time they come out. Thank you very much.
Dr. Iran, that was a lovely summary of the problems going on at the moment. And I wonder if I could open the floor to the chairs and any questions for 5 minutes, please.
Sir Jayakumar here from Kerala. Thank you for sharing your concerns, and it was wonderful to hear from you after some time. So actually, I have read some of the articles written by you about the training, about the concerns you have given. Like, recently the National Medical Council, they were coming out with the competency-based curriculum and formative assessment. Do you think that will solve some of these issues? Like, if you have, say, it's not a time-bound program, say in 3 years you complete the MCS, you will have a system where you get into the course and ask the competency, you will be promoted to the next level, and then as and when the competency is coming, you can come up or you will remain at the same level like that. And the formative assessment with regard to that. And that is, I would like to have your opinion about it, sir. And like when we look about the previous question, the previous sessions, we were talking about the registries and the regulations and all. Maybe as professionals, we are not taking up such matters in a proper way. Maybe the trainer and the trainees both are important. So we have to look into ourselves also to some extent to say, okay, we have to be more we have to convince the government that these things are important and we have to go forward and do something like, because our association doesn't have a say in policy making. That is what I feel that. So I would like to have your opinions. And probably from Dr. Kumud also know your. Yeah.
I think what the NRC is doing, it is a great job. But competency-based training, if that can be brought out, but that should not be something which goes on and on, because if it goes on for a long period, then naturally the candidates will be discouraged. Though we have got the positive points on that one, that this may induce the candidates to work hard and reflect on the trainer also, that what sort of a trainer he is. So if we are introducing that competency-based program, in that case, we should have the proper audit also. That how much the trainer has taught the residents, how much the trainee has imbibed that one, how much hours of work he has put in. And in that light, we should assess the trainee. That will be my take on that one. Yes, it is a good concept. And if it is carried out in the real sense, it will be really nice. Of course, the research process, the reference, all these are important. In fact, one question was raised, whether our trainees, they should have the research in their curriculum or not. It is a part and parcel of the training. They have to have some research papers even before they can appear for the final exam. This is mandatory. At least in AIIMS, they are not allowed to appear in the exam if they have not produced 1 or 2 papers, not the case reports, 1 or 2 original papers. And if these are not published or sent for publication or accepted for publication, only then they are allowed to appear in the exams. That is mandatory, not only for the MCS trainees, but for the MS trainees also. We have to have research process. The young minds, they must be induced to the research methodology. There is a special course of the research methodology which is taken by the biostatistician, and the residents have to pass that exam before they are allowed to appear in the final exam.
Okay, sir. Well, thank you very much. So I think we'll carry on now. We've got the last half an hour left, and if I can share my screen, let's just.
Thank you very much. Thank you.
Very welcome indeed.
Okay.
Let's just see there, and we will. Okay, can you see that?
Yes.
Wonderful. Okay,
yes.
So I've been given this task.
Full screen.
It's not full screen?
No. Full screen view. It's
okay.
Oh,
I know what to do. Hang on. This should be full screen?
Yes.
Yes.
Okay, perfect. I'm going to talk about how, having heard so much about our trainees and what the problem is how do we future-proof talent, and why do we need to do that? And what exactly is talent in the first place? How do we recognize that? It's such a nebulous thing, and everybody has a different definition of talent. But one of the things that seems to go across everywhere is that it's an appreciation that it might be something natural and innate, something, an aptitude or a skill that you're good at, and not necessarily something that you have to learn through. Maybe you were sort of born from it. I sort of dispute some of that. But or do you look at it that way, or do you look at it from the point of view of Aldous Huxley's, Brave New World, written almost 90 years ago, where we have, I reckon he took it straight out the Hindu caste system, where you have this top echelons here who are the super intelligent, going down to all at the bottom who are doing sort of menial tasks and so on. How do you see talent? And everybody has a different way of understanding this. So my own summary would be that it's an evolving product of an environment that allows an individual to be nurtured on some skill that's either innate or acquired, and that they're able to perform that task to the highest centile if you compare it with the general population. By that I mean your cohorts. It has a learning curve. There's a period of peak performance, which can be improved and kept going by repetition and the addition of more skills, and sadly, which has an inevitable decline. But unfed, it can turn even the most passionate to apathy. So now this is something which in fact has just been covered, the whole idea of how we as seniors need to recognize the talent, accept our mandate and responsibility to do what our remit was, which is to train the juniors to have the skills and confidence to practice independently. And otherwise, we might as well rely on physician's assistants. And I have been amazed at the quality of some of the physician's assistants who have had no medical background whatsoever. The hand skills, I can assure you, a couple of them at least are better than fifth-year surgeons, that some of them that I have seen. And that's got to reflect somehow on where we might be going wrong. The whole idea of looking at talent and what we might do about it, really, I think we have to go back to management and insurance companies and so on who are doing this day in, day out. James McKinsey started his company 1926, I think it was, and along with his colleagues there, they came up with certain principles. One of which was, and I don't know how you'll see this, was the up and out. That if you were not progressing and you were not being promoted, then really you should be shown the door and asked to leave. Then we have his colleague Marvin here, who then came up with lot more principles around how to structure this. And it's very similar to what we would accept in the medical healthcare system. So to put the interests of the patients here before corporate revenue, tell the truth, even if it challenges certain norms and we might upset people, perform only work that's firstly necessary and which can be done well. And then went on from the same company about war for talent. What was that? War for talent was a cry to appreciate, to allow institutions to appreciate that their success depended actually on talent and how to invest in it. So what is it that we need though? Is it something we need for now, or is it something we need for 5 years' time, which is always difficult even to gaze into a crystal ball because so much is changing so rapidly? Are we just filling in a basic need, or are we serving a skills gap? And you know, technology is galloping away and we have to remain exceedingly flexible. And how do we prepare and plan for this? So the AON, which is an insurance company, has come up with lots of strategies on doing this. And I've sort of modified some of their pointers that they give. There are 9 specific criteria. One is that you've actually got to review what skills you have in the workforce, in the institution. And how do you recognize that in the skills? Do they fit with the policy, the strategy for the business to go ahead? And the next one is you have to keep updating that framework of the competency you have. And what does that include? That includes really identifying, in this case, physicians that have certain characteristics. I would argue that for a surgeon, and maybe even, you know, all physicians nowadays need all of these qualities in the modern world, where you really have to grapple at a leadership level with so much of business and administrative duties. So yes, curiosity, you know, without that, you don't have passion. You need the desire and ability to learn. You need that drive. I don't make that distinction between surgeons and physicians anymore. I think many of the physicians' specialties are just as hard to get and just as rigorous. And to get to the top requires no less of all these qualities. That you have to be agile and be able to not just welcome, but to deal with change that is so happening. We see it all the time, like the way we've responded, you know, not just infectious diseases, but surgery. Every aspect of healthcare has had to do this with this pandemic. The respect for and appreciation that we are going to be handling data all the time, and that is a necessary part of our duties. We have to, that is really, we've got to be married to this data, without which we can't function, because it actually gives us a metric of how good we are at what we do. And it's a way for us to validate what we tell everybody else about what we do. And that can be seen plainly and compared to. And as Jain put so decently, this is never for punishment, but it is really to understand where things go wrong, how to improve it. Of course, at the very top end and the bottom end, there's always a carrot and a stick. That we have to be accepting that technology is rapidly changing and doubling, you know, so rapidly. That we have to learn to be strategic about not just now, but later. So there's more than just your surgical skills or your skills at the bedside. You need to have a certain degree of business acumen, interpersonal skills, collaborative skills, and to be able to navigate through the digital and virtual world has become necessary. So much of the work pattern has changed. Jain has moved from Papworth Hospital, where everybody had offices. My office was enormous, gosh. And now none of them have offices, but they're managing exceedingly well and even managing to have breakfast at home before they get to work. So it's changed, frightening at first, but I gather it actually works from some of the colleagues I hear. Jain may feel differently. Mental fortitude, and then the desire and ownership of your own lifelong learning, and of course, the mindset that's necessary with what we've just heard about expertise and the ability to teach. The other one is, how do institutions do this, or healthcare institutions build, borrow, and buy? These are ways of upskilling, reskilling, of job relocation, rotation, mobility within the career structure, that is absolutely necessary. Or you actually buy the whole ship, you buy the expert and the team. What works best? But these are things that we have to give some degree of thought process to. HR is not just somebody that for you finds and employs someone, goes to the administrative part. They are intimately involved and can be made to be intimately involved and should be so in terms of the strategy. They have some very valuable skills where they can use feedback from previous employees, ongoing employees, to acknowledge, motivate, and find the right people, how to get the job profile done appropriate. And of course, role profiles. What exactly are they? They need much more thought than just to say, I want to employ a cardiothoracic surgeon or a cardiac heart transplant physician. The profiles have to be much more rigorously thought through. So everybody then can be held accountable in fractions, but much more easier to do so than a nebulous title where you don't know how many components that actually covers. There's got to be rewards and ability to recognize and encourage the youngsters, and of course to consolidate the values and behaviors that you wish to have in your institution. Then finally, I'd like to go to discussing that you need really a smart talent. Sorry, forgive me. I'm just going to go back. A smart talent data. So this is, as I said before, integrating the employee experience with the job profiles and how the HR is becoming increasingly important in finding the right people. Sometimes we're not so good. And in fact, the exams and tests are notoriously bad at prognosticating on how well a surgeon might do. Not sure about how that relates to physicians. So well-structured interview techniques that the HR personnel are very good at give a much better idea of the prognostic value of how you might develop or how good a surgeon might be when you take them on initially. You have to invest in talent. You know, that goes from the mentor, the encouragement, how you delegate, how this was all about the trainees. You have to give them something to keep their passion alive. And of course, we have to continue to evolve that institutional culture. So we have to find metrics that allow people to be attracted to those values, that engages them to those values and that environment, and finally retains those important personnel. Now, I'd like to talk a little bit about, when we're talking about talent and retaining and future-proofing, I want to go through some of the problems. If we look at this, which is really the doctor or nurse-patient ratio, in the middle, as would be expected and aspired to by the WHO, and we look at what's happening in the emerging nations, and we are miles away. That ratio is vast. It's just 1 to thousands. But in the West and in Australia, you'd find that that is much better than what WHO wants. And yet, those same nations are saying they want to get even closer. For them to get closer means that the emerging nations are going to lose even more talent, and their bars of ratio is going to get even wider. So how do we deal with that? And this is just an example from the US, but it's just as like, it's the same story goes in Europe, and Jain will tell you how everybody's poaching doctors from everywhere, from the Indian subcontinent, Africa, for example, in Canada particularly, and just an astounding figure of 24,000 surgeon shortage in the USA in just 3 years' time. Where do you think they will come from? And the ones that go are being picked, so they're the best talent we're losing. What do we do about that? And this is what happens. I see the world slightly upside down, and where we're losing all this talent when we desperately need to keep them at home. But until we fulfill what Dr. Iran has just said in terms of changing the culture and the environment where our trainees are empowered to learn and progress and become independent practitioners as they aspire to, this is never going to be achieved, and we'll forever have this hemorrhaging of talent. And of course, this is again being partly covered. There's a poor entry interest. Last year, I think there were no takers into cardiothoracic surgery. There's I'm not sure about the physician side, but certainly in the surgical side, as it's been said, and this is reiterating, it's not a homogeneous and unified training system. Different places seem to do different things. Trainees are at different levels. Often there seems to be no logbook. And this leaves trainees with an unclear career progression, leaves them frustrated, despondent, And then they have this overseas factor, which then becomes an attractive thing for them. And they go, and many of them, of course, never come back. So what are the pull and push factors? What are those drivers that goes on this sort of vicious cycle where only few are returning once they leave? So I think this really involves a myriad of variabilities, personnel, institutions that all need to buy in to make sure that we can develop a system that allows us to keep a good fraction of our trainees sufficient to serve the nation that is a growing nation in terms of demand for cardiothoracic surgery and certainly thoracic transplantation, for which there are very few trained staff. And yet so many centers are wanting to be open. So on the one hand, yes, I think as mentioned, we need to be careful about how many centers there are, because just duplicating centers really doesn't help outcomes. You cherry pick, and that means you may do well. You'll have wonderful results for those you cherry pick, but you disenfranchise 80% of patients that would otherwise have done well with a well-trained team had you been able to have it. But it's difficult. There are only about 5 or 6 transplant-trained pulmonologists in the country. And as we heard before, maybe 2 or 3 really, by experience, well-trained cardiac transplant cardiologists. So what are the solutions for this? Improve local training, professional environment. We need to create the opportunities to feed that passion and drive and sustain it for the duration of 6 years at least. And not forgetting we have to do more in that fellowship years when they're really specializing. At the moment, there's some ongoing discussions post-Brexit with a lot of EU doctors perhaps having left, that there is a potential partnership with the UK NHS, how that would partner with India in terms of nursing talent and pool, and how that could be exchanged, and those nurses come back and benefit India while we provide from India the necessary skills and the manpower shortage that England is suffering at the moment, across the sector, not just in healthcare. And what about recognizing talent as being a national resource? I remember years ago, I was asked to give a talk in Zimbabwe about what to do in Africa. And it is far worse a situation there than it is here. And I sort of said, well, your trained nurse or doctor is no different to your ingot of gold or platinum. There's a price. And if countries want them, yes, well, tell us how many you want, speaking what language, we will produce them like a clone army. There will be a price for you for that. And that income allows you to train sufficient others to keep here, and perhaps with the addition of those exchange programs that can allow them to be sort of better skilled, or at least see a different mode of practice. Because what I do agree that was said earlier on is that local solutions need, local tailoring, and we can't just adopt something from outside. And I'm the first one to recognize, having come here last year, that you can't just bring something out and plonk it down here. It just doesn't work. We need to have really local solutions. What is this? So brain drain, as people call it, there's nothing wrong with brain drain. It's completely normal. Human history is full of individuals wanting to better theirs and their families' welfare and career prospects by going abroad. We can't stop it. You shouldn't stop it. But you need to create the environment that might not want them to go in the first place. So what do we do? What can we do? Certainly in our discipline, we can create exchanges. We can have clinical research partnerships, not just in country, as we heard this morning about research, but overseas, institutional twinning perhaps, to get much closer twinning, trust. This often helps the surgical institutes where it takes time to develop that trust and then allow the trainee or the junior fellow to get the hands-on experience that's absolutely crucial. And it's not wanting a handout at all. This is a close-knit thing that is always stronger. And we need to reverse. How do we reverse the trend then? How do we reverse the trend without not just limiting the loss, but we actually need to bring people over perhaps. I mean, like I've come here and my son tells me, having looked at this thing called 80,000hours.com, it's from an Oxford institute. They've realized that 80,000 hours of career. And the question is, what do you want to do in those 80,000 hours? what's your passion? How are you going to have an impact on society? And this seems to be the new generation thing about having impact at a societal level. So I'm thinking of how, and I look at Jain, and so I've come up with this concept of Action 10,000 because I've entered that last 10,000 hours of career. And for those who are in that last 10,000 hours, or just coming to the very end, what can we do? I think we can attract people like Jain from Europe and elsewhere. Instead of just retiring and going off, they have so much to offer, whether they be Indian OCIs or in fact foreign experts of foreign nationality, to come and for a period of 6 months, a year, whatever they choose, to come and actually at the ground floor to start mentoring and teaching and training and passing on their overwhelming experience, which often just goes away the day they retire. And those are just ways in which we might gain and retain. And finally, I'd like to tell you this wonderful story. So this in the middle, on the left-hand side, you'll see the team. This is from Austria. In the middle, just behind, on the right-hand side is Arezu. She's now the director of the heart transplant unit there. And this is them bringing back their first DCD heart, which they then transplanted actually on the night, exactly 52 years after, on the same day that Christian Barnard did his transplant. And that's the patient there, top right, day 2. Now that's actually a husband and wife team. Now on the left, you'll see there Andreas Zuckerman, ex-president of ISHLT. And just to tell you how you train, retain, and future-proof your talent. This is for the ladies. And look at the number of women in that team. And you know what's happening there? Andreas is down there looking after his kids, feeding and changing diapers, while his wife is out there running the show, doing the transplants. And he's got 2-3 months paternity leave to do this. And I think he's probably finding it more stressful than being in the operating theater. But there are all sorts of ways in which we can do this. And of course, many countries in Europe have amazing government policies that allow these things. So it's not just training, it's also welfare, quality of life that we need to think about. And on that note, I'll end because we might have some questions. Thank you.
That's a fantastic talk, and I think so, and a very exhaustive talk from the management point of view also, and you have covered majority of the management points. And on a lighter side, the exhaustive list that you had enumerated for the quality, for the talent proofing, I think so it itself becomes a very difficult task to be a cardiac surgeon then, if you exhaustive list. So that's the reason probably that we are lacking enough cardiac surgeons in India. I think so the main reason I would just like to add 1 or 2 comments is why we lack the cardiac surgeons in India is, one is the creative minds are not inclined right now, that this millennial people or youth, this creative people are more inclined towards a short period of profession with good outcomes, both from their financial point of view and from the satisfaction point of view. So they want to work for another 20-30 years, that's all, and then they want to live a happy life. Whereas in cardiac surgery, your career starts only after 30 years. Practically your career starts after 30 years. So that is the reason why not many people are really interested. But on the other side, what I have observed is with the Ayushman Bharat coming in, now the more avenues are opening up for the talents, because many centers are coming up. I have seen it in Gujarat that n number of centers have come up for cardiac surgery, and this all new surgeons are really getting a job there, getting openings there. So this is a good welcome step. I think so indirectly this Ayushman Bharat or the Yojanas will help this cardiac surgeons to have this more job opportunities. And third and important thing is, as you said, Action 10,000. I think we should need people in India who should lay down their legacies, because there are few surgeons like Dr. Girinath or Dr. Cherian who have laid down a huge legacy. There are n number of doctors who have been trained below him. But apart from that, there are not many surgeons who have a really good legacy behind. Thank you.
Umud, I thoroughly enjoyed your talk, and in many ways, yours and Balram's talks were totally complementary to each other. I think they touched upon the same areas and very valuable, very insightful. I liked your McKinsey's statements quite a lot because, basically that tells you how the concepts have changed and what are the strategies being adopted. By and large, the points that you have made, they apply to any field in life, not just in medicine, whether it is industry or whatever. And to some extent, they have always been applicable even to medicine. But now with the explosion of knowledge and with very easy availability of such extensive knowledge, it becomes even more important for people to learn all these techniques and to utilize them to the best of their abilities, not only to further their career, but to see what else they can bring to the table. With that in mind, I think I'm a little bit depressed at seeing what is happening in the last 2 years. There are hardly any takers for cardiology and cardiac surgery fellowship programs in many centers, even good centers. So why is it so? I mean, how come our young guys are losing interest? Is it that by the time they really start settling down, they start earning, they have done MBBS, then they've done DM, then they've done or MD or MS and then MCH, a guy who's in business or the guy who's in IT has started earning 10 years before them, and he has started doing much better in life. That appears to be a mindset for many of them. So this lack of interest in medical specialties is particularly worrisome. It is very nice of you to say that, people who have done very well abroad, they should come back like many of you guys are doing. But how many people would do that? Very few. I know any number of people who have worked and at the age of 55 or 60, they say, now I'm retired, I'm going to enjoy life. They go around traveling all over the world. Very few people think of that. Our environment also, I don't really blame our young people, who want to go abroad and settle down. Why is it that IT industry is managing to retain all the good talent, and the medicine cannot retain? There has to be a reason. So is it early opportunities to earn better money, better pay, lesser opportunities, not as good training as it used to be? You see, what has also happened is earlier when we were younger students, the entire talent used to be in government institutions. Now with the private, large number of private hospitals and institutions which have come up, their focus is something different, number one. And a lot of people in government hospitals who are in the middle of their career or who are reaching the peak of their career, they leave and join these institutions. And many of our prime institutions are now devoid of that much of talent. Doesn't apply to everybody. It may not apply to places like All India Institute or some of the premier institutions. But these are the places where the young talent has to be taught and nurtured. Private hospitals do not teach people. They basically provide service and very good service. They fulfill a major need for the society, but they are not the places where young doctors would be trained and nurtured. So I think these are some of the issues which are, unless there is a major change in the policy or pay structure or facilities or research, as you mentioned, these are all very, very important things to my mind.
Well, thank you. Are there any other questions or comments from the audience or from the faculty? I think the point of that whole session was not only to present the landscape, but also for it to be provocative enough to actually stir some thought times, I hope, for the seniors to reflect on what are really our responsibility and how we need to turn around the ship. I mean, I know Dr. Aram spoke a lot about the trainees and their responsibility, but unless we change that environment, we're not going to get the newcomers. We've got to be the ones that inspire and enthuse. And so there's got to be some concerted action from the society, and you know, INSHLT, the Cardiothoracic Society, HFT, to come together and have some sort of a policy, because what has been described to me, I didn't know how bad it was. It looks, you know, very bad for our discipline in terms of newcomers, when in fact the requirements in the country are so vast still. And every week I'm amazed at how big this country is, when every state is a country almost in its own right. And so we have to do better. I'm going to pass this on then to Jose. Are you there to say the final words this evening?
I think Dr. Jose is called to the theater.
Right. Anybody from the Society for Heart Failure and Transplantation there still, from the executive?
Dr. Nandakumar is there.
Oh, wonderful. Dr. Nandakumar, would you kindly just say a few words at the end to wind this up in the last minute or so?
I think, yeah, sir.
Good evening to everyone. It was really informative and very educated talk. Each talk is very impressive, and we had a lot of things to learn from here. These talks. See, one is the registry. See the need for the registry. I mean, I feel that see what we lack is the secretarial assistance for each of the surgeons. That most of the time the surgeons need to do all these things. That is one of the reasons probably for not entering the data so well. And then the training program, everything was very, very extensively covered. And Dr. Kumud has done a wonderful job in organizing it and conducting it, and moderating it so extremely well. I thank each one of you for participating in this, and on behalf of the Society for Heart Failure and Transplantation, I thank one and all.
Thank you so much. And we have closing just on the dot of 8 o'clock. And we'll hopefully see you tomorrow.
Thank you.
Good night.
Good night.
Good night.
Once again, thanking everyone who attended today's session. Thank you so much, Dr. Kumud, for moderating the whole event. Wishing a pleasant evening to everyone. Thank you.